Okay, thank you. Good morning and good afternoon. I take this opportunity to welcome you to this webinar. So I'll be your MC for the first hour. And in terms of why we are here, we are looking at COVID-19 and beyond, accelerating use of evidence to maximize on opportunities to improve health and livelihood of adolescents and youth in Kenya. So how did we get here? We have a steering committee members who are represented by the logos you can see on the screen. So we have planned a two-day meeting, which is half-day meeting each day on the 8th, which is today, 2 o'clock Kenya time to 6 o'clock. And tomorrow, starting again 2 o'clock to 6 o'clock. So this work we are going to be sharing this week, these 2 days, is really a collaborative effort between the steering committee members with PMA as the secretariat, ICRH Kenya giving the necessary support. So what are the objectives of this meeting, or what are the objectives? First is to discuss adolescent and young people research findings and best practices. You will appreciate that this is an inter-organization meeting, and we are bringing together different organizations. We hope to emphasize use of data and evidence for decision making. We are hoping to formulate and document actionable and strategic policy, program, and advocacy recommendations in the era of COVID-19. At the end of this two-day symposium, we are hoping that we shall make available data and evidence for decision making, and we shall be able to document the recommendations in the symposium report, which will specifically be looking at policy issues, program issues, and advocacy issues. With that overview, I would like to invite Martha Kombe, who is from former president of Youth Advisory Council, to give her remarks. Martha, the floor is yours.
Thank you very much. Just confirming if I'm audible enough.
Yes.
Okay. So good morning and good afternoon from this side. Ladies and gentlemen, my name is Martha Kombe, Program Officer, Straight Talk Foundation, Kenya, and the immediate former president of the Nairobi Youth Advisory Council. As I look around me in this symposium as a young person, I must say the reproductive health era is here. And being the largest population group in the nation and globally, we the youth are the most vulnerable of the groups when it comes to reproductive health issues. We all can testify that the impact only intensify over time. It is the very same adolescents and young people of today who face the worst effect in the future. But far being passive victims, young people all over the world have begun to fight back. We are taking up spaces and taking initiative, but this can't be possible without someone holding our hands. Whether through education, technology, science, or law, young people far and wide are tapping into their skills, speaking up for the reproductive health rights and education. Take, for example, the Nairobi Youth Advisory Council. In 2018, we were taken under the wing of the Department of Health in the Nairobi Metropolitan Services. The faith that the health department had in us to have solutions to our own issues was a huge milestone, and it has over the years yielded fruits in the managing and, of course, preventive of reproductive health issues at the grassroots level. This, of course, has been with the help of the like-minded partners that we see here, and we will see them presenting. For the years, we have seen other counties replicating the Youth Advisory Council structure in their adolescents and young people evidence to keep proving over and over the meaningful engagement of this structure that it actually works. We have seen amazing strides that have been made by the counties like Kilifi and many other in mitigating or getting to the targets of ending teenage pregnancy and other reproductive health issues. I'm sitting here today, though, to mention that as we are celebrating these achievements, there is a lot that still needs to be done when it comes to adolescents and young people's programming. We are the last generation that can end the reproductive health issues, and we can, and I believe we will. As a former president of YAC, that is the Youth Advisory Council, Nairobi Metropolitan, I still state that as a council, we are committed to helping young people to take voice, to take action, to protect our future. We do this by raising youth voices on the reproductive health gaps at the grassroots level and by increasing the youth participation to address health choices. Today, I see many champions around here. I'm very proud that they have been holding our hands in this space, here and now. And this symposium is evident of it. Do you believe in us? Will you stand with us? Thank you.
Thank you, Mother, for this presentation. I would like now to invite Professor Marine Tamaman to make her presentation. Dr. Uma Oruga, are you in the house? Because after Marine, it will be your chance. Professor Marine Tamaman.
Good afternoon, colleagues, friends, and thank you so much, Peter and Mary, for inviting me to say a few words. If I am allowed, Mr. Chair, I would like to share my screen.
Please go ahead.
Can you see my screen?
Yes, we can.
And just a few words on a study we did recently on the impact of COVID mitigation measures in Kenya on reproductive health with a small team here at AKU and with UNFPA. I'm not going to take you through all this. That would take too long. But so the idea was really to examine the potential ways of the COVID mitigation on SRHR, and we focused on Mombasa, Nairobi, and Kilifi. And we looked at population growth, maternal and newborn health, adolescent health, pregnancy in adolescents, and gender-based violence, harmful practices. So let's say that without going, I'm going a bit fast, without going into too much details on the findings, we will share them with all of you. I want to focus on one of them, which is the effect of COVID-19 on the utilization of sexual and gender-based violence services, which is really a big, big problem, as most of us know, but it's here also reflected in statistics and in qualitative research. So let's say from April, in many counties, there was already a lot of sexual and gender-based violence, but in many counties, it really has increased from April and May, and it is still a big problem, mainly for young adolescent girls and boys. And here we see a few of our statistics that are also being collected by Ministry of Health, working groups, and we can see that the number of reported cases, and they are only a tip of the iceberg, are really going on. This is confirmed also by qualitative findings, and a lot of factors that can play a role is, of course, a lot loss of income, the curfews, the lack of movement, loss of esteem. And we have a number of I'm not going to show them all, but from the qualitative research, it shows that it's really a problem in many settings, in rural and urban settings in our country. So we haven't seen really an increase in adolescent pregnancies. We have seen more girls coming to antenatal care, but we are still waiting for the number of deliveries to make a statement on that. But sexual and gender-based violence is really a big, big problem, and not only in Kenya. So I would like to call attention and focus on that, because we have had meetings recently with WHO, with UN Women, with UN agencies, showing that it's really a shadow pandemic. So we shouldn't close our eyes. We have to look at the vulnerabilities of the adolescents, the young people, and not only of the COVID-19, but also the shadow pandemic that we call the pandemic of violence against women during the COVID times and before and after. Thank you, Mr. Chair. That was my contribution.
Thank you very much, Prof. Marine. I would like now to call upon our guest speaker, who is Dr. Gitahi Githinji, the Group CEO for AMREF Health Africa. Dr. Githinji.
Thank you very much, Prof, and I hope you can hear me, and really grateful to the previous speakers who also helped set some context for the things that I'm going to say. Today, there's a lot to say in a meeting like this regarding all the data and statistics that we have on youth and adolescents, and all the statistics of socioeconomic pressures and suicide and mental illness and teenage pregnancy. And I know that's going to be discussed during this session. But I want to have one message and one message only, which I'm going to talk about. And I must thank you, Professor, for inviting me with your steering committee. So I'm delighted to be here on my own behalf and on behalf of AMREF Health Africa. The message I want to send is that as Kenya is now looking to change of government next year, I want to title my very quick remarks to, if you don't commit to protect us, why should we vote for you? If you don't commit to protect us, why should we vote for you? And I think it's time that the youth took this seriously, especially because the youth make the biggest voting bloc. And actually, the protection of adolescents and youth is in the hands of their government. It is not something that we as civil society can do on our own. It is not something that individual youth can do on their own. The role of government is to represent the assets of the people. They are custodians of the assets of the people, and therefore it's the people themselves who should demand what needs to be done, and it's the people who should decide what government to have that would protect their interests. So if you don't commit to protect us, why should we vote for you? Kenya has a big youth population. That is not debatable. There are statistics out there, median age of just shy of 19, and more than 50% are below that. And I think 15 to 19-year-olds are about 25% of the population. When I look at the data on education, secondary education, and you see the number of young people who transition to 18 every year, becoming voters every year, there are more than 1 million people, meaning that between one election and the other, you have 5 million new voters, and all young. And that's an important statistics to look at as I discuss this. Now, young people obviously provide opportunities for a country's development, and also, they also present an opportunity, like we call it. We say there's demographic dividend. We talk about the fact that the young people can increase labor market when they grow above 18, when they're well educated, they'll bring innovation. But at the same time, young people and a huge young population has huge health demands. Provision of health services, sanitation, water, education, housing, and employment. And all these are needed for us to build adequate human capital. And human capital is really a combination of the total sum of the health of an individual, the education of an individual, and the nutrition of an individual by the time they get to the level where they can be participating in a country's health economy. And that would be probably, if you look at the World Bank definition, that would be by the time you get to 18, the total sum of your education, your health, and your nutrition would add up to whether you're 100% human capacitated, or you're 50% human capacitated, or indeed 30% human capacitated. As we know, Kenya probably has a human capital index of 52%, meaning by the time our young people are getting to 18 years, 48% of their potential to participate in socioeconomic development has already been eaten away, and eaten away by what? Low quality of education because of all the challenges that that actually affect the young people, poor health, and poor nutrition for when they are young before 1,000 days. So if we can work on these things, then we can start to build the human capital. But between these two areas of economic development and the huge potential of young people, but also the challenges that the young people have, is the word hope. And hope may sound like a simple word, but hope is what we must protect. And I'll talk a little about how we can protect that hope, because hope is the last thing that we lose before we stop trying, before we have mental illness, before we commit suicide, before we have violence. Hope is the last thing that we lose. So let's talk about demographic dividend for a minute, as that is the hope a country bears on its youth. And a lot of politicians, a lot of development leaders have sold this demographic dividend as something that we must see as something we need to celebrate about our young people. That, oh, we have a huge youth population, therefore that's our demographic dividend. But this hope, the demographic dividend, is, can only be built when we have a healthy, educated, young population that has less children than their parents. Because the whole concept of demographic dividend, if properly defined and if easily defined, is basically saying that those who are working must be more than those who depend on them. And this is the challenge that we are having with our young people. That if 1 million girls are having largely unprotected sex between 15 to 19 years, 1 million boys are also having sex between 15 and 19 years, largely unprotected because we refused to protect them. And also, about 1 million boys and girls are having their sexual debut before 15 years, but we refuse to accept it. It means that we must protect this sex with information and health services. And if we don't do so, we may as well forget demographic dividend and throw it out of the window, because we are going to have more dependents than the working population. Because girls, underage mothers, teenage pregnancy continues to be divorce, and therefore we may as well forget demographic dividend. The aim of this definition of demographic dividend and the simplicity of it is to say that when a girl is entering work, or when a boy is entering work, whatever form of work, they must have less dependence than those who are working, so that they can create wealth. But if we do not protect the young people before they enter the working age of 18 and above, then we have more dependence than them by the time they enter the working age. If you have a girl, for example, who has Kenya's first stage of pregnancy average is about 18.2 years. But that kind of average hides a lot of the data that we have young age mothers. We have teenage pregnancy at 15. And if people are having sex at 15 and they get pregnant, it means that by 15, they have a dependent. They are not working. By the time they are 30, they have a dependent who has a dependent, because they have a child when they were 15, and that child probably has another child. So by 30, you have 2 dependence levels. And by the time you get 45, you have several layers of dependency. And this is the concept that we must actually fight against if we are going to actually say that we can create demographic dividend and protect adolescents and young people. Now, we know very well that the contribution of young people to our age-specific fertility rate by women between 15 and 19 years to the national fertility rate is almost 40%. So we know that we have the data, and we're talking about evidence policy making here. That's what we are talking about. And we are only talking about fertility rate. We are talking about probably access to family planning. Only our data only shows us access to married women, whatever their age is. We don't know, we do not have data of unmet family planning need for women who are not married, because we have decided if they're not married, they don't need family planning. So many factors contribute to these things. And we like, if you look at the adolescent sexual health, sexual and reproductive health policy of the Ministry of Health, we talk about, for example, the contribution of this high age-specific fertility rate to be abused, you know, child marriage, poverty, lack of information and social services. But the same policy, the adolescent sexual and reproductive health policy, guarantees provision of sexual and reproductive health services to adolescents at all levels and at all levels of service delivery. Yet, no family planning services are provided by community health workers. They only provide condoms because they're not allowed to provide hormonal contraception. Yet, when you go to level 2, which is the dispensary, and level 3 health center, there are no youth appropriate or friendly services that are appropriate for adolescents and youth. And finally, whereas this policy actually asks that the Ministry of Education provides age-appropriate comprehensive sex education, it does not, and actually calls out, including in presidential speeches, that providing this to underage girls is criminal. With this approach, there is no demographic dividend. There will be no socioeconomic development, and the socioeconomic pressures, violence, mental health challenges will continue to escalate. So for me, as I close, is to say, young people have their future in their hands. And that future is not in meetings like this, yet this is important. It is not in conversations. It is in the call that I'm trying to make to young people today, to endeavor to meet every single presidential candidate in this country, each one of them who are going to be looking for their votes, create a coalition of young people and demand a meeting with each of them and force that meeting and force them to commit to support the existing policy, not a new one, the existing policy of adolescent sexual reproductive health and rights. And if they do not commit to it, then do not vote for them. And basically saying, if they do not commit to protect your future, why should you vote for them? Thank you very much. And back to you, Professor Gishangi.
Thank you very much, my colleague and my classmate, Dr. Gitahi, for very inspiring guest speech. Just to note, and I think your last words are very powerful, that rest demand to be protected by our future governance or governance structures. So we truly appreciate this. Just to remind the participants that you can ask your questions through the chat area and we'll be able to have some responses by the end of this session. But it's really truly notable that every year we have 1 million new voters. And I think as politicians, we need to think about it. And we need to think about the protection of total health so that then we can reap demographic dividend. So thank you very much, Dr. Gitahi. It's always a pleasure to listen to you. Now it gives me my pleasure to invite Dr. Murwa, who is going to officially open the meeting for us. Dr. Murwa. Dr. Murwa, kindly unmute.
Thank you very much. Thank you very much, Daktari, my teacher. Thank you for the opportunity on behalf of the Ministry of Health to make opening remarks. All protocols observed, ladies and gentlemen. Globally, as well as in Kenya, there is a ranging debate regarding health and well-being of adolescents and the youth. This is exemplified by the government's commitment at the ICPD 25+ conference last year but one. Of the 17 government commitments, the first addresses adolescents and youth. Government committed to employ innovation and technology to ensure adolescents and youth attain the highest possible standards of health. Efforts will be made to eliminate teenage pregnancies, new adolescent and youth HIV infections, and harmful practices such as child marriages, while at the same time ensuring universal access to friendly, quality reproductive health services and information to the youth and adolescents by 2030. This commitment was informed by the recognition that adolescents and youth are disproportionately affected by poverty, limited access to use of sexual and reproductive health services, teenage pregnancies and their associated complications, harmful cultural practices, and high burden of HIV infections. The government is currently responding to challenges of adolescents and youth through various mechanisms, including but not limited to implementation of activities for the Vision 2030, Africa Agenda 2063, activities to address Sustainable Development Goals 3, 4, 5, and 10. Adolescents and youth is a critical population which needs special attention. Adolescents between 15 and 19 years make 11.1% of population, with slightly more female, about 2.6 million compared to 2.5 million males as per the 2019 census. The youth between 20 and 24 are about 4.5 million Kenya, 4.5 million people, which is about 9.4% of the population. Adolescents tend to be have poorer health indicators compared to older women. The current COVID-19 has not spared adolescents and youth, which is likely to result in further deterioration of the health indicators if nothing is done. The government has taken bold steps to contain the pandemic with success, allowing the county to ease restrictions. Unfortunately, we have experienced already 3 waves of surges in infections. And as our CS always notes, we must not lower our guard if we are to avoid further surges in infections. There are things that have worked well. The rollout of guidelines for provision of health services have greatly reduced the interruption in access and use of health services. Notwithstanding, there still remains concern that persons seeking health services may get COVID-19 from such visitations. Allow me to make it crystal clear that measures the government has put in place prevents individuals from conducting COVID-19 by visiting such facilities. And our health facilities are safe, and individuals should not fear getting the services they desire, even as we say that people can get infections through hospital visitation. The mass media campaigns is bearing fruit, and Kenya is now about, Kenyans know about COVID-19, and majority are adhering to the regulations and guidelines, although there are a few who are not doing so and are endangering themselves and the lives of others. The government, with development partners, is rolling out vaccination program for COVID-19. Though I commend Kenyans turning up for vaccinations, the uptake has been fairly slow, and the supplies have also had a challenge. Countries which have nearly vaccinated all their populations are opening their economies with minimal or any restrictions. We need to aim at vaccinating all eligible Kenyans to allow some normalcy of life. It will require all of us to get the vaccination to vaccination centers and take the vaccine. For those who may have questions about the vaccine, the MOH staff are available both at the stations, through the Chanjo platform, and in the offices to ensure that these clarifications are given. The fact is, vaccines are safe and are saving lives. As of 6th September, cumulatively 2,414,857 tests had been done, of which 240,430 Kenyans had been affected by COVID-19. About 229,000 4,206 have recovered, while unfortunately 4,705 have lost their lives. Kenya has received 5,146,780 doses of vaccines. About 2,870,303 persons had been vaccinated with, which is about 3% of population being fully vaccinated. The challenges of adolescents and youth, though known to large extent, the impact of COVID-19 population in this population is being understood. It is in this context that Inter-Organization Symposium, COVID-19 and Beyond, Accelerating Use of Evidence to Maximize Opportunities to Improve the Health and Livelihood of Adolescents and young persons in Kenya, is coming at an opportune time. I am informed that the research findings from different organizations touching adolescents and youth will be shared. This is probably the way to bring different pieces of evidence can be collected to give a fuller picture rather than one piece of evidence to inform policy, programs, and advocacy. As you share the findings, be aware that adolescent and youth policy is due for review after serving 5 years, and there is ongoing process to develop the family planning policy. Findings to be shared in this meeting could inform such documents. We need to continually and proactively generate research findings which can inform and drive policies and programs. Ministry is committed to ensure policies and programs are informed by data. Notable is the fact that the ministry cannot do it alone. There is need to strengthen existing partnerships and forge new ones. Partner activities need to address the priorities of the ministry, such as generation of evidence to inform policies and programs. We need to evidence on who works for adolescents and youth if we have to implement targeted programs. Through routine data, though routine data is improving, we still need more research to generate actionable recommendations. Government is also stepping up its contribution to health with the objective of eventually financing health through domestic financing. This process is being fast-tracked given that Kenya has attained lower middle income economy status. I take this opportunity to remind the participants of the importance of data for decision-making. I thank the organizers for bringing together this diverse array of researchers to a common place to share these evidences. As a ministry, we embrace data for decision-making. With those remarks, I would like to declare this symposium officially open and wish all of you fruitful discussions. My name is Dr. Andrew Mulwa, for the record, the Director of Medical Services, Preventive and Promotive Health in the Ministry of Health. Thank you.
Thank you very much, Dr. Mulwa. Again, it always gives me a pleasure to speak with you and to work with you. So thank you very much for that speech and official opening our meeting. I would like now to invite, and I hope Dr. Mulwa and others will be able to stay on, to listen to the keynote presentation on the value of evidence for decision-making. And Dr. Ajayi Zuru will be making that presentation to set the tone for the two-day meeting. Dr. Zuru.
Let me just, all right. Good afternoon, everybody. You can see my slide, right?
Yes, we can.
All right, thank you. All protocols observed. I'd like to thank the organizers of this very, very important meeting, and also would like to acknowledge the government officials and the director who opened the meeting for us now. I'm really just going to throw some ideas there just to emphasize why it is very, very important that we should put evidence at the center of all the efforts that we are putting in to really address the challenges that adolescents and youth are facing in the COVID-19 era. And I want to start by just highlighting this slide here. I work at the African Institute for Development Policy, AFIDEP, And this theory of change, or our approach in influencing policy, or in trying to improve outcomes for adolescents and young people and development outcomes in general, I think kind of outlines why it's important that we should all think about putting evidence at the center. So at AFIDEP, we focus on strengthening capacity for evidence use in government. We build partnerships with decision makers and researchers as well. And we do actual synthesis and translation of evidence and generate evidence to inform decision-making in 5 areas: population change and sustainable development, health and well-being, environment and climate change, governance, as well as education. So the sort of medium-term outcomes that we try to change are very, very central, and I think they speak to what we are all trying to do here. We try to strengthen political commitment and the enabling policy environment where decisions are actually made. And we also help to promote use of evidence in improving the design and implementation of the actual interventions and programs that affect lives of young people and adolescents. And finally, we try to make sure that resources are allocated to improve budget allocation. And with those, we believe that then you're going to have improved access to services and use of services and improved well-being. But as I start, I want really to come in by pointing out that decision-making or policy-making processes are complex. And when we come to adolescent and young people's sexual and reproductive health issues, they are very, very contested, as we all know. This is an area where everybody has a voice. In some medical issues and so on, if it's TB, whether it's HIV, people will tend to defer to the professionals. With even on issues to do with COVID, people were saying, show us the data that that can demonstrate the extent of the problem in our area. But when it comes to adolescent sexual and reproductive health, everybody has an opinion, whether it's a parent, religious leaders, community leaders, and all of us sitting here. We have views about, at what stage should our children start being taught about sexuality and so on. Some people don't want services to be available to young people. So it's very, very heavily contested. And when we talk about the role of evidence in informing decision-making, in protecting the lives of adolescents and young people, we have to note that evidence will not be the main, will not be the only, and in many cases, not even be the main factor that policymakers are going to be looking at, because they also have their own views. And there are a lot of other people speaking in the audience. And there are all these, people who are interested in having a say on this. But the point that we always try to do, and we emphasize in the work we do at AFIDEP, and we should all be doing, is to say that when we emphasize that evidence should be at the center of the decision-making processes, the evidence will help us to make sure that we set the right priorities, to set the right policy priorities, to understand the problems that are there so that we can set the right priorities. It can help us in guiding how resources are going to be allocated. It will help us inform effective design of effective interventions, inform effective implementation of those interventions, but even more critically, inform scale up of the interventions. Because at the end of the day, if we have to achieve the demographic dividend that has been already mentioned in the discussion, if we have to put young people as the driving force of Kenya's development, of Africa's development, it's about scaling up the interventions that are being done there. Adolescents and youth area has 1 million of things that are going on, small activities that are there. Ultimately, we need to make sure that we identify interventions that have the greatest promise, interventions that have been proven to have the biggest impact in improving the actual outcomes, and promote those so that we put more resources to them. So it's also important to note that decision-making regarding adolescents and young people goes on at different stages. I tend to define policy making in the way WHO defines policy making. It's not the policy that sits at the ministry headquarters, like I think the government official, the director, just talked about the adolescent policy, adolescent sexual and reproductive health policy being revised. That's a policy, yes, but we need to take a broader view of what a policy is. A policy, as far as WHO is concerned, they talk about the decisions that are being made to improve healthcare, to improve the delivery of health services, and to improve people's lives. So we're talking about decisions that are being made in terms of priority setting, decision that is being made about how much money should we put in family planning versus malaria. That's a policy decision. When you look at decision making, even at clinic level, should we use community health workers to deliver these services versus people just coming to the clinic? How many days in a week are we supposed to do antenatal healthcare services and so on? So decisions are made throughout whenever somebody is making a decision on how healthcare should be delivered, that's a policy. And I think when you look at that, actually we tend to move away from saying use of evidence in policy making, because a lot of us tend to think that policies are these big national policies. We tend to talk about really using evidence in decision making, which is the title of this talk here. So when you talk about agenda setting, whether it's a formulation of interventions, whether it's at implementation level, whether it's evaluating programs to see which programs are working and which ones are not, the types of evidence we need at all these stages is very, very different. And I think if we want to talk about really decisively and comprehensively address adolescent and youth challenges that we are facing in Kenya, we need to make sure that we are investing in all these levels of evidence that will inform decision-making at all these places. And when you really analyze the type of evidence that is mostly generated in our field, agenda setting, defining the problem seems to be the easiest and most common type of evidence we can find. But when it comes to saying which interventions should we actually use and how much money should we put, when it comes to costing, when it comes to learning, when it comes to actually learning to discontinue interventions that are not working and reinforce those that are not working, those are the areas where we have the biggest gaps in evidence. And part of it is because there's less communication between program implementation and those who are doing research, but also because our investment in research has focused on descriptive research and very little on implementation research. So we need to focus on really strengthening that. And a big part of it is also looking at issues to do with translational research. There's already a lot of evidence out there on adolescent and young people's sexuality. WHO has come up with high impact interventions that are there. A lot of other players have evidence. In many cases, when we are designing new programs, we don't pay attention to already the existing evidence. So it's not just about generating more evidence. It's about questioning ourselves on how much of the existing evidence we actually need to be using, and making sure that we create platforms, whether it's in the ministries, all our organizations, we create platforms that will allow continuous review of emerging evidence and making sure that we are not just implementing programs because the programs were funded, but actually try to determine or to guide the funding decisions to align with the evidence, what the evidence is showing. A critical thing that Dr. Githanji already talked about is the issue about the demographic dividend. When we're talking about evidence, I think we need to show, especially given that, as I said, the area of adolescence and sexual reproductive health is heavily contested. One of the critical things we need to do is to make the investment case, because very few people would argue with an investment case. Ministers of finance, they want to know, of course, maybe if we talk about the human rights argument alone, they can buy it and so on, but people also want to note, if we put 10 billion shillings in adolescent sexual and reproductive health, how is that going to help the country achieve Vision 2030? And the investment case, the demographic dividend, allows us to make that investment case because it allows us to talk about, one, how do we create a youth badge? A lot of people tend to say Africa has a problem of having a youth badge now, but in many cases, even Kenya, we don't have a youth badge yet. What we have is a child badge, because if you are having over 44% of your population below age 15, that's really a child badge. When birth rates go down, as Dr. Githinji said, that when people are having now fewer children than their parents and grandparents, will now create a youth badge, which will become a working force badge, and down the line, it will become an old age badge. And we know that to create the youth badge, the investments that need to be made there, changing the norms, female labor participation, education, and so on, are at the center of improving the well-being of young people. Then we have to increase contraceptive use, reduce child marriages, and so on. And issues about, access to safe abortion services are very, very critical to make sure that we don't lose the lives of young people. And in the end, what that will do is that it will create the youth badge, which will become the working age badge. But for the working age badge to be turned into the demographic dividend, then we have to make those investments in education, in skills development, in family planning, in health. There have to be jobs that are going to be created. There have to be social services, and governance has to be addressed. We can't achieve our goals when corruption continues to be at the rate where it is going now. Where will the money to invest in schools, in education, and in creating more jobs in the economy come from? So it's very, very critical that at the end of the day, we need to emphasize this investment case on why investing in adolescents and young people will actually propel Vision 2030, African Union's Agenda 2063, and so on. But on the other side of the coin, we shouldn't sugarcoat the message. What will be the cost of inaction? If we don't make these investments, what is likely to happen? They can be catastrophic. It will be hard to fight poverty. And more critically, there might even be civil strife of the nature that we saw in Northern Africa about a decade ago. So evidence that shows this, I think, the benefits of making the decisions, but the benefit also the cost of inaction will really propel policymakers and all stakeholders to make the right decisions. When we look at COVID-19, I think one of the greatest things that has happened is that it's been a major public health disaster, as we've seen, but it's also one thing that has helped everybody demand for evidence. That has gotten everybody to say, what is the evidence? If we are saying we are doing a shutdown, or we are closing down the another part of the country, or Nairobi is going to be on shutdown and so on, people are always asking the question, why is that decision being made? What is the evidence that is driving that? And we know that for the most part, a lot of the policies that were made were driven by evidence that was generated at global level. But as we go down with this pandemic now, we all know how to live with it. There is now increasing demand that we have to generate local evidence, not only on looking at the biomedical aspects of the pandemic, but also going more into the socioeconomic impacts, the long-term health impacts of what COVID is doing, not only in increasing the number of people dying from COVID, but also how it's affecting utilization of other critical services like contraception, reproductive health services, and so on. And using that evidence to make the argument on why reducing investments in these other areas like sexual and reproductive health is actually going to even have a more dire impact on our economies down the line. We saw last year when COVID came up, I think we saw in the press in Kenya, a lot of people came up and said, oh, because of COVID and because kids are out of school, the number of pregnancies have gone up. My colleague Bernard Onyango at AFIDEP actually said, okay, we know that this is a concerning matter, but he went into the DHIS tool and did analysis to say, okay, where were we in 2019 at the same time that we were this year? And what he saw was that actually the number of pregnancies in 2020 compared to the same period in 2019 had actually gone down. So it doesn't mean that this was not a problem, because even the lower levels were were very, very high. But I think it's important that we all need to speak from an evidence case to avoid speculation. So if we want to address issues to do with COVID, part of it actually, it might be that pregnancies were actually higher than before. And that the reason why we recorded lower levels is that because people were not going to the hospitals because they were afraid of going to the hospitals, thinking they might contract COVID there. But the evidence that was being cited was not being looked at properly. And as you can see here, everything in 2020, the numbers were lower, but people were talking as if, oh, all the kids are getting pregnant and so on. So we need to make sure that we state the problem properly. We get the right data to look at the evidence that is there. Another thing just to note here is that when you look at the data that now we are looking at, I remember between 2015 and 2016, when we had a project at AFIDEP with the Ministry on adolescent sexual and reproductive health, we realized that everybody was talking about adolescents, sexual youth, sexuality being a critical thing. There was a policy and so on. But we looked at the form that was actually being used for reporting, and we noted that this form didn't have a lot of the indicators, and we worked with the ministry and incorporated a lot of the indicators there. And these are the data that we are looking at now. And I think what I'm trying to emphasize here is that we all have a responsibility that when we talk about use of evidence, it's not just research or the papers that are being published there. To what extent should we optimize already the DHIS data that is being collected throughout the health sector? We should also look at how to optimize use of other data, whether it's DHS, whether it's the PMA data that is being collected there, so that we really optimize the analysis of this data. 2 years ago, we had another project with UNFPA, 3 years ago, where we're looking at the 5 districts that contribute most to maternal mortality. And we realized that a lot of money had been pumped into those provinces, into those counties, but nobody could answer the question, what impact has this money been done? We remember the First Lady led, the program on reducing maternal mortality and so on. A lot of money was pumped there. So we need to make sure that we optimize the use of these institutional data systems to help us understand what is happening as far as our indicators are concerned. What are the lessons on COVID as we go forward? One of the issues that is coming up is long COVID. There's a big gap there. A lot of people now are having COVID for longer periods of time or having some, psychosocial impacts of COVID. And some evidence in the US is showing that although young people who get COVID do not get, very, very sick, but they tend to be having these long-term symptoms that don't really get them in the bed, in the hospital beds and so on. But so in our situation, we have to start looking at these issues. To what extent are our young people being affected? We know, of course, other people are more affected, but let's start adjusting our research to answer these questions and understanding that evidence uptake is really very, very dynamic. At AFIDEP, we've kind of said that now we shouldn't be talking about evidence dissemination. We should be talking about evidence uptake. And when you talk about evidence uptake, it means that you as an organization, your own sort of approach is going to be different. You can't just go to Serena and have a dissemination seminar there and expect that, once you pass on the results to policymakers, things will change. We have to be involved in the policymaking processes, participate in technical working groups. We have to be there, support the policy that is coming up there, because a lot of these things shift, a lot of these things change, and we can't just say the evidence you have today is the evidence that the government will use 2 years from now. So, Mr. Chair, I know I've run out of time, but let me just run through these 5 points I just want to make, and I'll do it quickly. What are some of the practical tips that we all need to take into account to optimize evidence use in addressing adolescent and youth challenges? First is really we have to establish these strong relationships with policymakers. As I said, we have to get involved. We should shift from saying evidence dissemination to really helping to promote evidence uptake. Second, we should also get policy makers involved from the beginning. The policymakers cannot be passive audiences in the evidence use agenda. We are now talking about co-creation of evidence and co-creation of all these tools and interventions that we are talking about. We have to partner with other non-state partners. Our work with UNFPA has meant, in many cases where we've worked in about 26 African countries at Africa in the last 10 years. In each of these countries, we've worked with UN agencies, and the UN agencies already have a mandate to advise governments. And when you go with them, you actually have, like, you can open doors, whether it's ministries of development, planning, health, and so on, that we may not be able to open ourselves sometimes as NGOs. We have to adopt a mix of strategies to get evidence used. It's not a one, you just go and say, we'll do this thing. It's a combination of things. It's talking to policymakers one-on-one, through seminars, it's through engagements and using third parties, sometimes engaging these other non-state actors, the UN agencies, even the development partners, the World Banks, because sometimes these organizations may have more leverage in getting our governments listen to the evidence than we might do ourselves, and putting our own universities and researchers at the center of the process. But I think the last but one point is really to say, promoting research uptake in addressing adolescent and youth issues is not a cheap thing. We have to invest in it, and each and every one of our organizations has to invest and have a wing that really looks at communication and evidence uptake. And the top management has really to understand and lead from the top for this to have this impact. It's also important to note that not all research is worth informing policy. There's bad research, there's good research, but more critically, research should be comprehensive. It's not somebody you go and do your small study, maybe in Homa Bay, and then you want to hound people in the ministry to say, oh, change your policy because of this. The policy evidence that should change policy or inform policy should be systematic, should be comprehensive, should be robust, should be timely, and should have relevance to the local context. So it's important that as researchers, research organizations, we should pay attention to that. And finally, I think the COVID era, what it has done is because we were not able to visit a lot of people, I think it has allowed an opportunity for all of us to leverage digital technologies in collecting data. So whether it's using telephones or engaging people, even in delivery of services and so on. So I think we should all try to optimize this. This is what I wanted to really highlight there, Mr. Chair and the organizers of the meeting. Evidence is very, very critical. It's not the only factor, but when evidence is really considered to be reliable and contested, a lot of people will listen and make decisions with evidence now being at the center. And I think that's what we should all aim to do, so that we don't lose an opportunity to change people's lives just because we don't know what we need to do or how to get that done. Thank you.
Thank you very much, Dr. Zuru, for that presentation. Don't worry about the fact that you have taken a little longer. I'm sure we'll save time. As we transition to the next scientific session, please join us on Twitter. The handle is Youth Gender COVID 2021. Share your thoughts, share your findings, share anything on Twitter. That's our Twitter handle. As I hand over to Karen Kabiru and Shannon Wood, the floor is yours.
Thank you all very much. And that was a very interesting opening session. And I believe the rest of the afternoon will be, or morning, depending on where you are. So thank you all for staying on for this first scientific session on sexual and reproductive health. My name is Caroline Kabiru, and I work at the African Population and Health Research Center, and I will be co-chairing this session with Dr. Shannon Wood. Woods, who's from Johns Hopkins Bloomberg School of Public Health. So I will be introducing the speakers or presenters before they speak, before handing over to Dr. Woods to chair the Q&A. Just before we begin, some quick housekeeping, just reminding you, if you do have questions, please use the Q&A panel and introduce yourself as you ask your questions. And then to the speakers, please take note that you only have 10 minutes and Dr. Woods will be helping keep you on point. So without further ado, we'll move on to the very first presentation, which is by Professor Gishangi, who we are familiar with, who'll be speaking about contraceptive dynamics during COVID-19. So over to you, Prof.
Thank you, Dr. Kabiru. I'll be sharing with you contraceptive dynamics during COVID-19, longitudinal mixed methodology study among adolescents and youth in Nairobi, Kenya. Next slide. So this is the outline of my presentation. Next slide. So this study, we have had 3 time points for data correction. Respondent-driven sampling survey, RDS methodology was used because we considered youth to have hidden population, hidden behavior. The first survey was done in June to August 2019. The second survey was done in August 2020 and May 2021. That's round 2 and round 3. We had monthly text messaging. We had virtual qualitative data, and we shall be sharing more about that. Just to note that all the ethical protocols were adhered to. Next slide. So this slide, I'm sharing contraceptive use. We note that the first round was about 58%, and second round was about 61%, and third round was about 53%. This is for 15 to 19. We see a very similar pattern for 20 to 26. Kindly note that round 2 and round 3, the difference is about 6 months. Next slide. And so what were some of the reasons for using contraception? And we see here classically the desire to prevent a pregnancy, to avoid an abortion. If one is not committed to their partner, that means they do not want to have a child at that time. Shame of adolescent pregnancy, wanted to prevent diseases, particularly when using condoms. And of course, the quote there is talking about peer pressure. So this is one of the things which then lead to contraceptive use. But you also note that myths and misconceptions were indeed deterrent to uptake of contraceptives. Next slide. Here we are sharing the method mix by different age categories. What we notice for 15 to 19 is overwhelmingly they were using coito-dependent method in the first round. It remained the same in second round. It remained almost the same at 77% in the third round. What you notice for 2024 is about 70% were dependent on coito method. The second round is about 62%, and the third round was about 59%. And that is expected because we are seeing that the 20 to 26 are indeed older and they may require methods which are much more effective. Next. Here we are sharing the source of contraceptive, and we notice that if you look at that slide, overwhelmingly you see pharmacy and public facilities to be the predominant source. Private clinics contribute very little. And therefore, the message in this slide is that we really need to think about sources of contraception outside the regular mainstream areas. But note, from first round to the third round, we have seen an increase in the use of pharmacy as an outlet for contraception. And that could be related to the fact that COVID restrictions may have contributed to this matter. Next. This is an important slide. And here the message to note is that we have about 29% of individuals who either switched a method or discontinued a method. But also of the non-users, we note that about a third of them, for the females, indeed adopted a method in about a year. For the men, we see also about 28% or 29% indeed either switching a method or discontinuing. But also reassuring is that about another 25%, 1 in 4, was indeed using a new method when they were not using in the previous round. Next. Here, we are looking at round 2 to round 3, which is about 6 months apart. And again, we notice a very similar pattern that there are people who are switching methods and people are discontinuing. On average, about 10% were discontinuing, and after 14% were switching methods. And we note that discontinuation and switching probably contribute to unintended pregnancies. And this is something we need to think about when you look at program level. What is the implication of this data? Next slide. This is particularly interesting slide. And here you're looking at individual level. People are using long-acting reversible contraception, short-acting, coito-dependent method, traditional method, and non-users. What we see is a big bucket of coito-dependent method becoming non-users, but also a big bucket of non-users becoming coito-dependent methods, movement almost in the opposite direction. And this is seen around 1 to round 2 and round 3, 2 to round 3. Next slide. And this is among young men, and we see the same pattern as for young women. We see non-users becoming users of coito-dependent method, a lot of coito-dependent method becoming non-users in both time points between round 1, round 2, and round 2 to round 3. Again, very important to note that people are using coito-dependent method are likely to become non-users, and the opposite is also true that non-users could become users of coito-dependent methods. Next slide. We note, and we did investigate the reason for discontinuation. We see very classical reasons, just like for older women, infrequent sex, partners opposed to use, not being married. And this is for both men and women. But we also note that from focus group discussions, negative experiences shared by among young people do indeed affect as a reason to discontinue a particular method. Next. Regarding COVID-19, we note that a lot of individuals, nearly 20%, were fearful they could get COVID-19 when they went to the health facilities, and we are happy that government has clarified there's no risk of getting COVID-19 with the current protocols. Indeed, 40% of male users and 35% of female users experience some kind of difficulty to access the methods. And we note that they were unable to afford services, health facilities were either closed or unable to access because of restrictions. So this becomes main important reasons at the first round and the second round. Next. And we see that between round 2 and round 3, I think the significant interventions the government has put in place has reduced substantially the number of individuals who are fearing about getting COVID-19 within the health facilities. We saw previously it was about 20% to about less than 10%. So that is really progress, because it means that people are getting to hear, and with those then people can access the required services. Next. So what are the key messages here? We notice that throughout the pandemic, coito-dependent methods are the main dominant for young men and women. Again, that is expected because they're using contraceptives for a short period of time for very targeted protection. We see contraceptive adoption increase between the rounds. And again, that has been borne by other pieces of data collected from Nairobi. We see that the need for contraception is decreasing, but there's further work which is required for us to know or to understand non-users, why they are not interested in using the methods. Next. So if you look at what does this mean, certainly policy implications, here we see there is need to address switching and discontinuation, public-private partnership, because the pharmacies were really a big supplier of commodities there. We need to think about them to increase access. If you look at strengthening comprehensive counseling to reduce switching and discontinuation, as well as addressing myths and misconception will be important. We need to address access and use, and certainly we need to be able to advocate for programs which increase access and use of family planning or contraception to adolescents and young people. Next. Really, this work is a joint effort, and I'd like to acknowledge all the individuals listed there. Next slide. And thank you very much, and you can follow us on those different social media outlets there. Thank you very much.
Thank you very much, Professor Gishangi, for that presentation. A reminder, if you have questions for him, please do put them on the Q&A panel. Next presenter is Dr. Anthony Ajayi, who is based at the African Population and Health Research Center, where he's an associate research scientist, and he'll be presenting about a paper titled, "I Was Strict, Understanding Reasons for Unintended Pregnancy Among Sexually Active Adolescent Girls." Over to you, Anthony.
Thank you very much, Caroline, for the introduction. Can you see my screen? Okay.
Yes, we can.
Can you see my screen? Okay, great. So the title of my presentation is "I Was Strict, Understanding Reasons for Unintended Pregnancy Among Sexually Active Adolescent Girls." So this was this, you know, again, if we've been following the conversation, you know, for a while now, we will probably, you know, we'll be more acquainted to the fact that the rate of early unintended pregnancy in Kenya is alarming. I mean, it's been reported in the media, and some research have also shown that in multiple publications. Getting pregnant at such a young age, like even as early as 10, 11, 12, 13, 14, 15, 16, even up to 19 years, can harm the health and well-being of girls. We've seen from research that when girls get pregnant, often they drop out of school, even voluntarily, or if they don't, they get kicked out of school. And many of them never return to school. And this has implications for their socioeconomic well-being in terms of their preparedness for labor force. Also, the pregnancy itself, especially for those that get pregnant too early, could also have some health implications. Studies have shown that they have more complications, even dying from pregnancy, compared to people that get pregnant as adults. So, so the question, but what we also notice is that there's also implication beyond physical health. There's mental health implication of all these pregnancies. But recently, there is increasing awareness of the dangers of early unintended pregnancy. And even girls themselves are aware of some of these consequences. But yet, use of contraceptives is still not optimal, and we are seeing high rates of adolescent childbearing. So the question is why? So we embark on this research to both understand the level of unintended pregnancy among young people, as well as the reasons, from the perspective of these girls, the reasons why they got pregnant. So this is a mixed method research involving quantitative and qualitative study. And it was conducted in Omar Bay and Narok. We sampled 1,840 adolescent girls for the quantitative arm of the study, but the analysis was limited to the sexually active adolescent girls, which is 1,110. And for the qualitative arm of the study, we interviewed 45 adolescents, 25 from Narok and 20 from Omar Bay. But in this study, we limited the analysis to those that were pregnant, 19 of them that had given birth or currently pregnant, to just understand from their perspectives why they got pregnant. So we define early unintended pregnancy as, we define unintended pregnancy as not wanting to have or not sure about having a child or becoming pregnant at the time of the index pregnancy. And then we looked at the contribution of factors such as age, marital status, contraceptive use, educational attainments, and as well as household factors and community level factors. And we use multivariable models to understand the factors that increases or reduces the risk of adolescents to early unintended pregnancy. Now, these are the interesting results. Of the 1,110 adolescent girls, 41.5% of them have experienced unintended pregnancy. That's about 2 in 5 girls that are sexually active have become pregnant. Now, of all of them, if we limit the analysis to those that were pregnant, to understand how many of them actually wanted to be pregnant, about 80% of them said they did not intend to get pregnant. So of course, of the 461, majority of them did not want to become pregnant. Now, in terms of some of the differences that we observe, those in rural area had increased risk of becoming pregnant, as well as those age 19 and 18. Also, those that only attain primary level of education had increased risk of early unintended pregnancy. Also, those that drop out of school also have increased risk of early unintended pregnancy. Those that reported that they've never used contraceptive also had increased risk of early unintended pregnancy. Now, for the qualitative findings, again, finding out from the girls themselves the reasons why they become pregnant. The first thing that they said was, I was tricked. Tricked in the sense that, they engaged in relationship, they were in love, so to say, and then when they become pregnant, the boys abandoned them according to them. So they were, dating. Also, lack of contraceptive information, accurate information before they initiated sex was another reason they said was responsible for their getting pregnant. So from the perspective of one of the participants, I think it is because I did not know how to prevent pregnancy at the time. I've only heard of the use of injection, and that was when I was already pregnant. And then there are also misconceptions about modern contraception. So yes, we were told, but we were told that if you want to, you have to have a child first, because if you get into use of contraceptives, you may fail to get a child. As in, if you start using protections before you have a birth, it may be a problem. Simply, it was basically saying that contraceptives can cause infertility, which is actually not supported by scientific literature. Another reason alluded to was lack of trusted mentors. Say, I don't have an older woman I can trust. If you tell them, they will know you are having sex and everyone will soon know about it. These are some of the reasons that came from this data, but I think it's also important that I share other reasons beyond this that came from another study I conducted, and one is sexual violence. Many of these girls did not willingly engage in sex, so they were forced and they got pregnant through the process. Also, poverty remains a challenge as one of the contributors to pregnancy. Some of them were just dating with the hope that the men would take care of them, and they got pregnant in the process. And then lastly, some of them also blame closure of school during COVID, as well as those that dropped out of school and were probably idle as some of the reasons why they got pregnant. Now, one thing that is also interesting is the fact that these are the views from the girls themselves, but if you ask their parents, or you ask policymakers and teachers why girls are getting pregnant, you see them say things like, oh, it's peer influence, they don't listen, things of that nature. None of the policymakers or teachers actually want to consider all these reasons that young people alluded to as the reasons why girls are getting pregnant. So there's a divergence between what girls consider to be the reason and what teachers, parents, and policymakers in some quarters think are the reasons why girls are getting pregnant. So what are the implications of the findings? Of course, we are seeing 2 in 5 girls that are sexually active getting pregnant, and most of the pregnancies are unintended. Again, showing that something has to be done quickly to end early unintended pregnancy. And then we also found that the rates we are seeing is higher than in the national average. Education is protective, so keeping girls in school is really, really protective. It's one investment that could help reduce early unintended pregnancy. Also, contraceptive use is also another important investment that could help prevent early unintended pregnancy. As you can see, those that reported to use contraceptives are less likely to experience unintended pregnancy compared to the ones that are not using contraceptives. Also, those living in rural areas have increased risks, meaning that intervention should focus on rural areas as well as urban areas, but even more so in rural areas. Now, taking together all these results, 2 interventions are really important. It's important to educate young girls about how to prevent pregnancy, especially on the education needs to be comprehensive and focus on all aspects of sexual and reproductive health, but more so on how to prevent pregnancy, because we can see that majority of girls are engaging in sex and they are not prepared to, and they don't want to get pregnant. Unfortunately, they lack accurate information on how to prevent pregnancy. So one key intervention is to actually equip them with knowledge of how to prevent pregnancy. But beyond that, there's also a need to improve access to contraceptives, such that the information is also supported with provision of services. But again, these are contentious issues, and I sometimes wonder why it's so contentious. If girls want to prevent pregnancy, then we should support them with the information they need to prevent pregnancy. So thank you very much. This is my presentation. You can read the full paper. It's been published. And I added this particular slide because of the reproductive health bill before the Kenyan Senate last year. There was a lot of controversy about the bill, and I feel this article sort of unpack what is in the bill. And the issue of comprehensive sexuality education was part of the bill, and we saw a lot of petition going around and a lot of misinformation about what is in the bill and what the provision is about. The provision simply wants to equip young girls with information. In fact, even in the bill, they talk about educating girls about abstinence, but yet it still did not scale through, and there were a lot of backlash. So I encourage everyone to read and follow through on what is in the bill. Thank you very much for listening.
Thank you very much, Anthony, for your interesting presentation. We'll now move on to the third presentation by Ms. Joyce Mbuthia, who's an Advocacy Outreach Coordinator at Amref Health Africa. So Ms. Mbuthia will be speaking about Meaningful Youth Engagement Framework Scorecard. Please proceed.
Good afternoon, everyone, and thank you, Carol, for the opportunity. Please confirm that you can hear me.
We can, thank you.
Thank you so much. So, as Caroline has alluded to, my name is Joyce Mbuthia. I work at Amref Health Africa. For the project.
Sorry, Joyce, your sound is breaking. I don't know if it's just me. Sorry, Joyce, please try again. Okay, it seems that Joyce may be having some technical issues. So in the interest of time, I'll ask that we move on to the next presentation by Mr. Francis Kundu, who's the Assistant Director of Population at the National Council for Population and Development. Then we can come back to Ms. Mbudia. So Mr. Kundu, please, over to you.
Okay, thank you. Also, I'll confirm that you can hear me.
Yes, loud and clear.
Okay, thank you. So I'll make this a brief presentation on the contribution of adolescents and youth to the unintended births in Kenya. Now, in terms of the outline, that is my outline, we will look at the introduction, then the wanted status of current pregnancies, also the wanted status of last-born children, born to women, and also the pregnancy in the last 5 years and the conclusion. So by way of introduction, I would like to say that fertility reduction is key in attaining a population age structure that will facilitate the achievement of a demographic dividend, because we need a youth bulge for this, and therefore fertility reduction is key when it comes to this. Also, the elimination of unintended pregnancies can contribute significantly to further fertility reduction. And this is because when you look at the DHS data, it shows clearly that about 49% of the pregnancies or births in the country in 1998 were unintended. And by the last DHS in 2014, it had come down to 36% of all pregnancies. So adolescents and youth have a contribution which they make to the unintended pregnancies and birth, and that's what we shall be able to see. Now, this is just an indication of how the population pyramid for Kenya has changed between 2009 and 2019. You can see in 2009, it was almost a perfect pyramid. But in 2019, what we saw is that at the bottom there, it has started to narrow. So it's an indication that we are moving from a child bulge to a youth bulge. And it may also be an indication that the number of births that have taken place over the last 10 years may actually have been less than the previous 10 years. Now, looking at the current pregnancies among females aged 15 to 49, now we just want to bring out the trend, what has happened between 1998 and 2014 in terms of the wanted status of the current pregnancy. And by current pregnancy, I mean for those women who are pregnant at the time of this survey. And you can see here that in 1998, 54% who were pregnant indicated that they actually wanted to be pregnant at that time. And this has increased over the years, and in 2014, that proportion was 63%. On the other hand, those who were pregnant and indicated that they did not want to be pregnant at that time, they wanted to be pregnant later. In 1998, that was 37%, and this has declined up to about 30% by 2014. Now, when you look at those who indicated that they did not want to become pregnant at all, but they found themselves now pregnant, in 1998, that was about 9%. Between 2003 and 2008, there was an increase there to about 18% and then 15%. And then the last DHS brought this down to, we showed that it was now at about 8%. Now, here, we've just looked at a comparison of the females aged 15 to 24 and those aged 25 to 49 in terms of the unintended current pregnancy. And you can see all along, it appears that the proportion of those who were pregnant, but they didn't intend to become pregnant is much higher. When you look at the females aged 25 to 49, you can see all through 98, 2003, 2008, up to 2014, their proportion is much higher. But the interesting thing to note here is that when you look at the younger persons, age 15 to 24, it appears their problem is that they are pregnant, but they wanted to become pregnant later. That is the main issue among them. Because if you look at what happened in 98, you find that 40% of them were in this situation. They were pregnant, but they wanted to be pregnant later, compared to 33% among the older females. And when you come to 2014, you find the proportion is 35% among these young females compared to 25%. But when you look at the older females, their problem appears to be that they don't want to become pregnant at all, but they find themselves again pregnant. And you can see the proportions are much higher for these older women. Now, also in the DHS, there's a question which women are asked about their last born child who was born in the 5 years preceding the survey. And from what we can see here, they're asked about whether the child was wanted at that time, wanted later, or not wanted at all. And you can see the proportion of those who wanted their last born has increased from about 50% in 98 to 60% in 2014. But when you look at the proportion who indicated that they wanted their last born to be born later, not at that time when they got their last born, you find this proportion has been declining from 38% in 98 to about 28% in 2014. And for those who indicated that, okay, they got their last born, but they did not want to have a child at all, you can see the proportion in 98 was 12%. It went up to 23% and then to 21% in 2003 and 2008. And then it came down to 12% in 2014. Now, when you look again here at the comparison of the wanted status of the last born child within the last 5 years, now you're comparing the last born child for the females age 15 to 24 and those age 25 to 49. And you find the situation is similar to what we had seen with regard to the pregnancy, that those who are younger, age 15 to 24, are indicating that, yes, they got their last born child, but they wanted the child to come later. But for the older females, I think their main concern is that they did not want the last born child, but they ended up becoming pregnant and giving birth to the child. And therefore, when you look at the younger females, 15 to 24, you find the proportion who got a child and they wanted the child later was 44%. But in 2014, this had increased again to 46% after having a decline in the intervening period. Then when you look at now the contribution by the females age 15 to 24 and 25 to 49 to all births that occurred in the 5 years preceding the survey, you find that for the younger females, that's the 15 to 24, in 1998, they contributed to 40% of those births. And this has declined to 34% in 2003. And then come 2014, this had gone down to 29%. So the younger females contributed to about 29% of all those births, but the older females are the ones who contributed to most of those births. Now, when you look at the unintended births that occurred in the 5-year period preceding the survey, then you find when you do a comparison between, again, the two age cohorts, you find that out of the unintended births, those aged 15 to 24 contributed to 38% of these unintended pregnancies and births in 1998. And you can see in 2003, the figure was 34%. 2008, it went to 36%. And then finally, in 2014, it went to about 35%. So what this basically shows is that the contribution of youth to these unintended pregnancies and births has not changed much over all this period from 98 to 2014. So it would be interesting to see what will happen when you get the results of the next DHS, which we hope will take place next year, to see whether this has changed further. So here, what it basically means is that young persons are contributing to about slightly over 1/3 of the unintended pregnancies and births in the country. So in conclusion, I'd like to say that adolescents and youth, age 15 to 24, have a significant contribution to the high level unintended pregnancies and births. We have seen it slightly over 1/3. And then by eliminating these unintended pregnancies and birth, in the country, it means that the proportion of these unintended pregnancies at birth can be reduced drastically, just by 1/3. So if we address this problem of unintended pregnancies and births among the young females, then it means that the total proportion of the unintended births and pregnancies in the country can be reduced by about 1/3. So thank you, and back to you, Chair.
Thank you so much, Mr. Kundu, for that presentation. We'll try Joyce Mbuthia again. So Joyce, please. And maybe Mr. Kundu, if you could stop sharing your screen so that she's able to project. Thanks.
Thank you so much, Caroline. I hope you can see my screen.
Yes.
Thank you. So I'll start with an overview of Youth in Action project. And so we are a youth-led and youth-driven, and then we are in 6 counties: West Pokot, Bungoma, Kakamega, Samburu, Kilifi, and Samburu. And then we use 3 approaches. One of them is voice. How we do that is to make sure that we are capacity strengthening the youth to be able to advocate for youth priorities within their counties on matters sexual reproductive health and gender equality. We have a curriculum, which is online, where youth are able to access information on how to do advocacy, develop advocacy strategies. And then we have, in terms of participation, we are saying that the youth need to be at the forefront of policy development process, not just as a formality, but right from agenda setting to policy development, to monitoring and evaluation. And in terms of skills, we also ensure that we capacity strengthen youth-led organizations, not just on advocacy, but also on, organizational development, monitoring and evaluation, social accountability. And one of the approaches that we are using is what I'll present next, what is we call meaningful youth engagement. So as a Y-Act, as I said, we are youth-driven. So we started by, going around. We have a youth portal where youth-led organizations register. We have around 3,500 youth advocates on the portal. So we leverage on these youth voices to be able to get the perspective of the youth. So through that portal, information was collected about what is this that we call meaningful youth engagement. We keep saying that the youth are the majority, they want to be engaged, but what is it that they mean by being engaged and being engaged meaningfully? Like you can see, one of the youth from Kakamega County said that meaningful youth engagement to him is about having the youth counted as leaders and stakeholders rather than just beneficiaries. And then another youth from Nairobi County said it's about giving youth a platform to voice their ideas and thoughts on policy. So out of the many voices of the youth, this is what was drawn as the conclusion of what the youth feel meaningful youth engagement should look like, as an intentional partnership between youth and an organization or entity. In this case, we do a lot of policy advocacy. So it's a partnership between the youth and the policy makers, where young people are involved, like I said, from agenda setting to decision making to implementation and evaluation. So in terms of the scorecard itself, it has 5 elements, but these elements are further broken down into 9 indicators. So when we say inclusion, we want the youth to be included in policy decision-making tables, and them to be represented in when the policies are being made at the counties or at the national level. In terms of capacity, the youth need to understand the policy process. We know the policy processes, especially the budgeting process from the government, it's a long process. So sometimes the hindrance to youth engagement is that they don't have that capacity. Then in terms of diversity, the youth are heterogeneous in the sense that they are diverse in terms of age, race, sexuality. So the marginalized and the vulnerable youth must also be find a spot at the table where policy and decision-making table is being done. Then transparency. In this element, the youth, clearly stated that the policymakers need to communicate if there's there's a process, there's a policy coming up, they need to communicate that to the youth, and they need to do it in a language and using the platforms where the youth are available. And then this scorecard is also a measure to hold the government accountable. Is the government, engaging the youth? And if they are we seeing policies that are responsive to the issues of the youth in terms of, the language, in terms of the programming, in terms of budgetary allocations? So the scorecard, we've been able to, roll it out. Initially, it was not digitized. Right now, if you visit our website, which I'll share shortly, you are able to have the digitized version of the scorecard. And then we've been able to do orientation of the scorecard to the policymakers. Like I said, in all the counties where we are working, we've been, supporting youth-led organizations to advocate for various policies. I'll be particular for Kilifi County. We've been pushing the government to domesticate the national menstrual hygiene policy. So we've actually ensured that we did a baseline in terms of meaningful youth engagement. Where are we as a county? And then once we roll out the process of policy development, we did again another endline just to see, document the evidence that actually the policy response to the issues of the youth, the policy language is there, the youth have been, recognized as stakeholders in some of the committees, like for example, the menstrual hygiene steering committee at the county level. And then county MYE scoring, one of the limitations is that for now, the scorecard is being used to just measure a policy process. And then some of the learnings that we've been able to learn from rolling out the scorecard is that it is a good way to amplify, the voices of the youth, and in terms of ensuring that the government really looks at engagement of the youth as a partnership rather than, because most of the time youth have been imagined to be problematic. They want to engage the policymakers in a way that is not appropriate. So how do the policymakers want to engage the youth, and how do the youth want to be engaged, so that it's more of a discussion? And how the scoring happens is that you put the policymakers and the youth on one table, then they score each other. Have you been inclusive? Did you communicate? Are you transparent? And then the scores are such that they are able to agree. So if, for example, the score is at 4, the policymakers will, give evidence why they feel the score is not at 4 and it should be at 5 or it should be at 2. So through that, it strengthens the relationship between the policymakers and the youth. And in the long run, it ensures that the youth voices in terms of the priorities that they feel are for them are actually accounted for in the policy documents. So I would wish to conclude there. Thank you for listening. And that's the link to the scorecard on our website. You can click that link and interact more with the scorecard. And then so that's how basically the scorecard looks like. And one of the key other things to note is that when you click the digital scorecard, it has two areas. One is you score as a youth, and then you score as policymakers. And then the scoring committee is usually comprised of a representative of the youth, ensuring, like I said, there's diversity and the marginalized and vulnerable populations within the youth fraternity are represented. Thank you.
Thank you so much, Joyce Mbuthia, for that very interesting presentation. We'll now move to the last presentation in this session, which is by Sal Mulyanga, who's the project director of the Advanced Family Planning. So over to you. Thank you.
Thank you, Caroline. And just briefly, Advanced Family Planning is an advocacy initiative at the Bill and Melinda Gates Institute for Population and Reproductive Health at the Johns Hopkins Bloomberg School of Public Health, and it is implemented in Kenya by JAPIGO. So I will be really discussing this very important topic. What more do advocates need from the data? And looking at this topic, and especially listening to many research findings that are done in this country and elsewhere, then the question is, what more do advocates need? So I'll try to, interestingly, my computer is not able to move to the next slide.
Please click on your PowerPoint window, and then you should be able to move to the next slide.
Okay. All right, let me just check why that is not happening.
Can you stop?
I will stop, then you can share what you have on your end, my presentation from your end.
Is the JHU team able to project?
Hold on just one moment.
Sure, thanks.
Yeah.
It's opening. Sorry, it's taking a moment. Shift some things around on the screen.
All right. Okay.
Can you see it now?
All right. Perhaps if you could make it a little bit bigger, that would be fine.
All right, the screen that I'm sharing it on is a smaller screen. Do you want me to make it wider? Hello?
All right. I think given the time, I could talk through it. I think there's no problem. Basically, when we look at what advocates need in this space, one of the things that advocates are very keen at is one very important factor. Basically, looking at, what data resonates with decision makers. And how can we know about this? Well, data need to resonate with decision maker concerns. In most cases, as researchers, go out there, think about the questions that we want to answer, do the research. But then that could not be necessarily the concern of the decision makers. The concern might be something else. Therefore, how many times do researchers go to the decision maker and say, okay, what is really a big problem? What is your major concern? What is this question that you like answered that needs research? And if one does that, then what happens is that the research that later on is presented to the decision maker is something that the decision maker was looking forward to. And therefore, advocates will find it easy to basically make a case. So that becomes very important. Now, sometimes advocates will use data from researchers, but then the data is not answering all the questions. For example, scale-up needs. Yes, the finding have said this is, it has come up with a wonderful outcome. But the decision maker might ask, how will it take to scale up this nationwide? How will it take to scale up this in the county? And sometimes even across regions. What will it take to scale up across regions? So that becomes very important. Sometimes you find there are recommendations. Actually, most of the research findings have recommendations, and advocates pick up those recommendations backed up with data and present to the decision makers. But the decision maker asks, what does it cost to implement this at a larger level? And you find that the research did not cost the recommendations, yet it becomes very important to the decision maker in knowing the cost of implementing some of these findings that we want to basically impact on policy, impact on practice. The other thing is, yes, we have the findings, but we go further to look at the implication, the possible implications across the various target sectors. Take, for example, if you have data, say 13% of teenagers become pregnant, whatever that proportion is. Or say annually, we have say about 400,000 teenagers becoming pregnant. Beyond that, what is the implication? Because advocates will so much want the implication of that, data on the implications. And across the sectors, if it is the Ministry of Health, if I just use a 400,000 figure, for example, just for purposes of discussion. What does that mean on the health system? How much of that proportion, for example, have complications? And what does complication, the cost of this complication of the health system? What does that mean on programs such as Linda Mama, insurance programs and all that, when we have these huge batch of young people falling pregnant? In the Ministry of Education, what does that mean? If you have 400,000, remember, the ministry, the government is giving tuition for these children, it's paying for tuition for these young people and making an assumption that they were at school. That tuition is paid, and for 3 months after delivery, maybe the money that is paid by the government is not serving its purpose. You have that big amount. If you look at a figure like that, 400,000, and each school is, say, assume a school of 1,000 pupils, how many schools are we talking about where tuition is paid and it doesn't get its purpose? So the implication, and that's a strong data, that it doesn't just look at people getting pregnant, young people getting pregnant, adolescents getting pregnant. It means something else. The same data, if you take it to the Ministry of Finance, it means something else. Look at what does that impact on the economy long term? What does that mean for initial investment made on these young people when sometimes it doesn't realize what's supposed to be? The social protection programs, those who are funding bursaries, we are seeing that in more years as they go by, we see increase in bursary allocations because the demands are getting more. Previous speakers talked about the vicious circle that this leads to. So basically, going further to have data on implications become very, very, very important that we really need to focus on. The other thing is data that debunks entrenched perception. Sometimes people get to know certain statistic that used to be a long time ago, and they think it is the same statistic now. And the perceptions are entrenched. For example, if we look at just pregnancies that has been spoken of, if a 15-year-old girl falls pregnant, the perception of many people that it's an adult, an over 18 person, young man that was involved here for this pregnancy. But it could just be a 12-year-old boy who was involved in this pregnancy. But the perception is that it's the adults. So the kind of interventions that will come will be more of a criminal nature. But if we had more data that actually shows that we have a lot of pregnancy among peers, it changes the kind of intervention. It changes some entrenched perceptions. And therefore, the more we look at this data that might not be available or might be available, but in just very specific geographies, then that will help the case for advocates, especially in debunking entrenched perceptions. Then we talk about less research populations. If you look at data in this country, the 6-year-old to 15-year-old population, there's very little data in that space. We get very much interested in under 5 and then 15 years to 49. But these particular data, in fact, I might not be surprised that some institution might even be removing some of these populations from their records. And what does that mean? It shows that these are research, in quotes, population. Interventions towards it might be meager. And advocates need this data. So let's think of what other areas, what other population, what other aspects that we don't have much data. Then I want to talk about data that is specific to geographies. Sometimes we have beautiful data, but if I'm a decision maker at a certain level, the data doesn't speak to me so much. And this is another challenge that we have. Second slide. On some of the recommendations. As we get to that slide, the next slide on what we need to do, advocates also need data on the cost of inaction. Sometimes people feel, oh, after all, if I don't do anything, there's nothing that happens. What is the cost of inaction to the system? Now, briefly, when it comes to recommendations, what are we talking about here? It will be very important that we strengthen collaboration and coordination among researchers. Because some of those questions or implications that we've said cannot be done by one researcher. Somebody else can do the other bit. And when we have that collaboration, it helps because research is also expensive. And also collaboration with advocates. The other thing is that researchers need to factor in advocacy in the beginning, not at the end. At the very beginning, thinking through. In most cases, we have research coming out and then now advocates take it up from there. But it needs to be factored in the beginning. Then we also need to develop a compendium of unanswered research questions so that the research we do is complementary. It could touch on things that another researcher would not have touched on because of other variables. And as mentioned here earlier, I think it was by Dr. Zulu, researchers to co-create research questions with decision makers. In that way, decision makers will be more, willing to actually implement that, even eager. And then lastly, advocates need to deploy evidence-based advocacy. Thank you.
Hello, thank you so much to all of our presenters. That was absolutely fantastic to learn from all of you. I see that there are a few hands raised. Given that we are short on time this morning, would you mind typing your questions in the Q&A chat? That would be fantastic. And thank you to most of our presenters for answering the questions as they have come in this morning. We really appreciate it, given that we are short on time. There are a few more in there, so I will take a look at those. A lot of them can be answered individually. So Dr. Ajayi, if you would mind getting back to Bernard on some of the clarifications surrounding your unintended pregnancy variable. And then I want to ask a larger question because it's been discussed across the presentations, and also I've seen it come up in the chat a few times, but it's surrounding male contraceptive technology and young men's engagement. And I think that this was particularly pertinent in Dr. Ajayi's presentation this morning, and thinking about that trickery piece and how we overcome some of those harmful social norms to better engagement. So that is a question that is open to any of our panelists. If you would just like to come off mute and go ahead and answer that, we only have about 2 to 3 minutes. Thank you.
Shannon.
Yes, Peter, I can hear you.
I did not quite get the question.
Oh, I'm sorry. Do we have any concrete recommendations across the panelists for how to best engage young men in contraceptive use? Apologies if that was unclear.
I would defer that to AMREF, which has been engaging young men and youth.
Okay, I think that we may be having some technical difficulties. That seems to be a common theme this morning. So I will go ahead and turn this conversation over to the chat, as I know that we are short on time. So again, thank you so much to all of our presenters, and we look forward to engaging with you in the chat. Thanks.
Thank you. Because of time, we were expected to have entertainment from the youth, but we propose we move for the next session. So I'm passing the baton to Jean Patrick and Eva, who will be taking us through the next session. Over to you, Jean and Eva.
Thank you all, and welcome to the next session. And good morning, good afternoon, good evening. My name is Dr. Jean Patrick. I work with the Ministry of Health Kenya. And my co-chair today is Eva Muluve from Pop Council. Maybe she can unmute and put her video on so that we can all see her.
Hi, everyone. Hello.
Yes, karibu sana. Welcome. So our session topic is on sexual health rights. And I just want to remind all of us that in Kenya, we have a constitution that is very robust, and it speaks to the rights of the people, and our young people are not left behind. And of course, in our constitution, it is everybody's right to health care, including reproductive health services. And therefore, our young people, like any other person, have the right to these services. And our policies, our guidelines, they are all aligned to ensure that we respect those rights as a country. So for this session, we are going to have some discussions. We have very able panelists, and we will have a glimpse of the legal and policy environment in our country, Kenya. We'll look at the challenges, the opportunities, and the implications of some of these policies. We will also have another session that will take us through the changing trends and perspective when it comes to reproductive health and rights. And then we will have two counties sharing their lessons or evidence of using data to inform intervention. So we'll be having two counties, that is Migori County and Samburu counties, sharing their experience, and also the use of data, translating data into evidence, and how they've done it to ensure that the interventions directed to young people are actually meeting the needs. So without wasting a lot of time, because we are behind time for now, I would like to invite our first presenter, who is Bernard Onyango. He's a senior research and policy analyst and the Build Program PED director from AFIDEP. He'll be taking us through the first presentation titled A Synopsis of the Legal and Policy Environment for ASRH in Kenya, Challenges, Opportunities, and Implications. So karibu sana, Bernard Onyango, and take it up. Thank you. Welcome.
Thank you so much, Dr. Jean. Thank you for this opportunity. So far, I've been listening to the presentations prior, and they build up nicely to this particular presentation, which is a synopsis of the legal and policy environment for ASRH in Kenya. I have three takeaways from my presentation, and the first one really is that Kenya has a strong legal and policy environment for ASRH, as Dr. Ajayi just mentioned, and we'll see this briefly. And then second, and we've been seeing this coming through from the presentations prior, there are indications that there is a mismatch between this positive legal and policy environment and ASRH outcomes. And lastly, that the country needs to address gaps in enforcement and implementation of the ASRH related policies. So we really have, a lot of, if you look at the legal framework, there are a lot of legal statutes that really support ASRH in this country. So I've listed a number of them on the left, including the Constitution of Kenya 2010. We have the Sexual Offences Act 2006, we have the Children's Act 2001, Prohibition of FGM Act 2011, and you can really go on and on. You look at the policies, and again, there's a raft of policies that, if they work effectively at implementation level, we would be expecting to see less of some of the ASRH challenges that we actually see in this country. And of course, this is anchored for adolescents. It's anchored around the ASRH policy from 2015, but there are a lot of other supportive policies, both within health. As you can see, the National Reproductive Health Policy to 2007. We've already had that, there's the Reproductive Health Policy 2019, which is in the pipeline, and unfortunately it became a bit contentious last year. We have if you look at education, you can look at the education sector policy on HIV and AIDS. And so many, supportive policies. So the National Adolescent Sexual and Reproductive Health Policy 2015 really aimed to bring some of these together and to enhance the ASRH in Kenya to contribute in realizing adolescents' full potential, as well as to benefit national development. And if you look at that policy, it addresses various thematic areas, in total about 8 thematic areas, including comprehensive sexuality education, sexually transmitted infections, looking at early and unintended pregnancies, harmful traditional practices, looking at drugs and substance use and abuse, and sexual and gender-based violence, among others, and also SRHR needs of marginalized and vulnerable adolescents. So I was glad to hear earlier on one of the speakers at the beginning reminding us that in fact this particular policy is due for it's due for a revision, since 5 years have elapsed since it was enacted. Now, that's really an opportunity to try and see where did we go wrong, where were the gaps in this particular policy that can be addressed in that revision. But much as we say that the policies, the reason why we say the policy environment is strong, if you look at those policy and the legal frameworks available, they address a lot of the barriers to ASRH. And this table just summarizes what we see in looking at across the breadth of the policies we have in Kenya, and I've adopted this from a very useful piece of work by PRB known as the Youth FP Policy Scorecard. So, for example, if you look at this table, most of those areas are shaded in green, meaning basically that is positive. For the parental and spousal consent, we really don't have an actual law or policy that addresses this. But on other issues, they are fairly comprehensively addressed. So, for example, when we talk about restrictions based on marital status, the National Guidelines for Provisions of Adolescent and Youth-Friendly Services 2016 make a very clear provision for youth to access family planning services regardless of marital status. If we look at the issue around access to a full range of family planning methods, we see that, again, the national guidelines on provision of adolescent and youth-friendly services in Kenya include contraception as a component in the essential package of service offerings to these young people. And so, I can go on and point out to a lot of policies that are very positive for these. I think one particular area that has been a little bit, that has been contentious and has not really moved forward as much as people, stakeholders in this area would have liked, is the comprehensive sexuality education. So, in general, there's an agreement that something needs to be done in that area, but how to operationalize it has become really problematic. And unfortunately, we haven't come to a conclusion on that. So hopefully, when the ASRH policy is revised, this is going to be tackled. But I think, as we've already seen, while the legal and policy environment are very favorable, or at least look favorable on paper, the outcomes, ASRH outcomes, make you sit back and pose the question, what's wrong, what's going on, and some of these issues I just listed 3. ASRH outcomes amongst young people that are of concern. So teenage pregnancies persist, and that level of 1 in every 5 girls between age 15 to 19 who are pregnant or already a mother has been, it's hovered around that figure for quite some time now, despite efforts towards addressing the teenage pregnancies. Another area you can think of is STIs and HIV, and young people aged between 15 to 24 really account for almost half of new HIV cases in this country. The statistics on sexual and gender-based violence are quite alarming, and for example, from a report from the National AIDS Control Council some time back, pointed out that 1 out of every 3 girls had experienced forced sexual intercourse by age 18. So I think, the issues, and they've been emerging as we've been talking, and I'm sure that we are going to see more of this emerge in terms of the evidence from the research being done on the ground. But some of the persistent barriers to SRH in Kenya that are really causing that gap between policy and outcomes include the inadequate information and SRH services for young people. A lot of our policies, unfortunately, are not backed up by very robust implementation plans. And where the implementation plans, there are also, in some cases, inadequate resources for implementation. So, for example, we know that the country has really been struggling with financing the family planning. And I mean, while it's a wider issue, but young people are affected in this scenario. Additionally, the issue of evidence has been mentioned by a lot of people. Unfortunately, one of the things you find when moving around and asking, so what's happening in certain locations, surveys that really are conducted that provide evidence for SRH are not as many as we would like them to be, or not as regular. There's been some work being done towards using the facility-based Kenya Health Information Systems to improve, evidence for decision making around the ASRH, and that has helped counties. But still, there are gaps, and you go to the counties. While, for example, people working in county governments want to take action, the question they ask you, but where is the evidence? How can we take action without the required evidence? Sam Mulianga, who talked in the previous session, pointed out to another major issue for ASRH. We don't have data for younger people, so a lot of it is even for 15 to 19. In terms of conducting research, it becomes a little bit more dicey, but we don't have a lot to say for those who are younger than age 15, because it's quite difficult to get data for those people at those ages. There's the issue around traditional and harmful practices that persist in this country, and this really it ties also partly with my last point there on bias and discrimination against rights of adolescents and youth to SRHR. So there's really partly this idea that young people should not be exposed to bad behavior in quotes, And this is, for example, when we talk about collaboration across sectors, some of the challenges that the Ministry of Health, for example, is trying to address. When you cross over to the Ministry of Education and the actors that Ministry of Education in schools, whether it's teachers, there needs to be some level of behavior change there and attitudes towards young people's rights to sexual and reproductive health. So a lot more will be said about this, but I also wanted to take this opportunity just to, to let you know that at AFIDEP, we are taking the opportunity of this particular symposium to add another layer of evidence from work that we have been doing with the University of North Carolina's Population Center under the Full Access, Full Choice project that is supported by the Gates Foundation. And so today we have just released a number of policy briefs based on research that we've conducted, providing from both primary data collection and the synthesis of secondary data that will help.
Sorry, Bernard, I'll have to interrupt. Your
Yes,
time is almost up.
That's really my last one, Dr. Jean.
Wind up.
Yes, that's really my last slide. So this will be available for sharing with the other participants. So thank you.
Thank you so much, Bernard, for that presentation. And just a reminder to all of us, if you have any question, kindly put it on the Q&A session. And for the presenters, we shall be alerting you on your time in the chat. So keep on looking at the chat so that we don't interrupt you as you present. So we go to the next session, the next presentation. It is going to be done by Korir Kigen. Korir Kigen is a program specialist, ASRH and youth at the UNFPA Kenya. And he's going to take us through reimagining sexual and reproductive health and rights for adolescents and young people, the trends and perspectives. Welcome, Mr. Korir, for the session. Please share your screen. Thank you.
Thank you, Dr. Jean. Good morning, good afternoon, good evening for those who are joining us from different places. Just want to take this opportunity to be able to share with you some of the perspectives that are emerging in regards to the very pertinent topic that we are looking at today, and that is the adolescents and the young people. As it were, I know a lot of speakers have been able to really allude to the criticality of this constituency, not only as a matter of equity, going by the population trends in the country, where more than a third of the population is largely made up of, the adolescents and the young people between the age of 10 and 24. And so really, the various decision-making that we make, the various investments that we make, of course, have to really take into cognizance, the population that we have and the fact that they really hold the key, to the current and future aspirations of this country. So specifically, just looking at some of the trends, and I know a lot of speakers have already alluded to this, we're still grappling with the whole issue of adolescent pregnancies, but not just, referred to the data that we have around the KDHS, but of course, just looking at some of the recent trends, more than 300,000 adolescent pregnancies in 2020. The latest estimates on HIV and AIDS really put again this population accounting for almost 34% of new HIV infections, and even worse, 41.6% of all adult infections. Now, just looking at the issue of early sexual debut, and from a study done by UNFPA and ICRH, in about 3 counties, we are looking at the median age at first sex being around 15 years, which is really something that is not desirable. Again, looking at the facilities which are considered to meet the threshold for youth friendliness, going by the Kenya Health Facility Assessment of 2018, we are looking at around 62%. FGM is still prominent or prevalent in around 22 counties. So, we have about 22 counties that are considered a hotspot. But last but not least, of course, in addition to a wide array of issues that have been spoken to, mental health. I think, this is something that really is getting prominence. And of course, the nexus between it and, SRH, both looking at the causality as well as the effect, whether you're talking about the pregnancy, antepartum, depression, postpartum depression, and many other facets of it that are linked to SRH, either as a cause or as effect of the same. Now, just a reflection on some of the dynamics really that are coming up. But just before that, just to emphasize of the fact that really adolescence is a critical area when it comes to laying the foundation for good health across the life course. And all of us would appreciate that more often than not, most of the factors that all behaviors that are initiated at adolescence tend to manifest later on in life, and with so many ramifications for that matter. And so really the importance of investing in this stage, understanding very well that this is where behavioral patterns are established, be it in terms of eating habits, sexual activity, substance use. These are likely going to be manifested in adult life. And also, just for example, looking at, for example, pregnancy among a teenager and the implications of the health of that particular teenager on the infant, critically will have an impact on the generation to come. So the investments in information services, and also most importantly, what we call the social ecological factors, family, the peers, the school, the community, and also the policy systems around the same become critical. Just a reflection on some of the trends that are either emerging or are manifesting with regards to sexual and reproductive health and rights for adolescents. All of us appreciate the dynamics of COVID-19 in terms of the implications on schooling, mental health, overall empowerment of young people, with the containment measures that we've had before in terms of programs. The other bit, of course, is the change of policy and legal frameworks. To a certain extent, we've been seeing some kind of trends that may curtail or influence or impact access to some of the sexual and reproductive health services by adolescents. For example, contraception without parental consent. Issues to do with curriculum limitations. And why I say this is that over time, there's been a lot of emphasis on abstinence, which is really a desirable goal for all of us. But the main thing that, again, that we have to appreciate is that we're dealing with a heterogeneous population. And therefore, as we deal with abstinence, we also need to really look at the curriculum being more robust to also tackle risk reduction measures like protection, and a use of condoms. Societal pushback, I think, is something that really is equally manifested. Looking at sexuality education and the pushback, by different groups, which clearly have different understandings of the same. Escalating humanitarian situations, and of course, there's a very, very big nexus between climate change and sexual and reproductive health and rights. Floods, conflict, drought, all things that are really with us more often than not. But again, what you find that most of the time, humanitarian action tends to prioritize, the basic needs and leaving other basic needs. For example, for girls, we are talking about menstrual health products, but also in the whole spectrum of reproductive health, the minimum initial service package, which really is critical in terms of ensuring that the sexual reproductive health and rights outcomes are maintained. The digital revolution, of course, with all challenges and opportunities, but of course it brings on board the whole issue of exposure to harmful content, but also issues of online safety. The sexual predators are scattered all over the place. Emerging behavioral practices, and I think really the importance of being able to appreciate that the context keep on changing. And that's why even as we design programs, we must design programs with the user in mind. New drugs are drugs like Lyft, new entertainment ways, the staycations in the Airbnbs that we see. And of course, then it points to the issue of really us being able to appreciate the new trends and dynamics if we are going to intervene appropriately in the current context. The other bit, of course, now is how do we confront some of these issues, and very quickly looking at, for example, the whole conversation around UHC. We need to really see how best we can be able to package these issues of adolescent sexual reproductive health, including issues of menstrual health management, from the preventive lens, looking at issues around sexuality education within all this conversation. There's really a need to shift focus, particularly from the whole concept of promoting youth-friendliness of services, shifting from the traditional youth-friendly corners, standalone clinics, to looking at it from a health systems approach. Adolescent responsive health systems really is the conversation to go around, ensuring that health services are friendly to the adolescents. There's also a need to build resilience of healthcare systems and also education systems to be able to respond to emerging changes like COVID-19 and other humanitarian situations. There's also a need really to see how best we can be able to intervene on some of the SRH issues affecting young people. And sometimes you find that SRH may not be the appropriate entry point. And so it's important then for us working in programs, practitioners, to then look at the lens that we can be able to have this conversation from the most pressing point of view, which is economic empowerment, leveraging on some of the economic empowerment programs to have the conversations and programs around SRH. Again, all of us appreciate that in 2019, we had a momentous summit called ICP 25 Nairobi Summit. We have a couple of targets and commitments which we must see through, either by 2022, like the one on FGM, or by 2030 for the ones dealing with child marriages, teenage pregnancy, new HIV infections. These really must be key pillars for us when we talk about getting political support, but also trying to really position ourselves, knowing very well this is the direction that the country should be taking. Again, appreciating that adolescents don't live in isolation. They live within a particular setup with various agents cutting across. And so for us to change the tide, we must really promote multi-sectoral coordination and response. The UK did this on tackling teenage pregnancy and managed to have the number of in a period of 10 years. So really bringing on board different actors and looking at an adolescent holistically to tackle this issue.
Sorry,
I think the
again,
issue...
you have to wind up.
All right, that's
Time.
fine.
Yeah, thank you.
Yeah, so meaningful youth engagement, I think I have to say that. Again, the data for the 10 to 14-year-old, very critical. And last but not least, the concept of bodily autonomy. This is very critical, particularly for the women and girls being able to make decisions about their health and well-being for us to achieve universal access to SRH services. Thank you so much. Over to you.
Thank you, Keegan, for that elaborate presentation on the changing trends among young people. And we now have to move to our next presenter, who is Lily Njoki from Migori County. She's the County Child and Adolescent Health Coordinator. and she's going to be presenting to us using evidence to inform adolescents and youth targeted interventions, lessons learned from Migori County. Karibu sana, Lilian Njoki. You have 10 minutes.
Thank you so much.
Karibu.
Thank you so much, Dr. Jean, and to everyone who is here. Allow me share this presentation from Migori. Basically, we call it, it's a multi-sectoral approach for adolescents and youth health in Migori County. Next. So as an introduction, we all know that adolescents and youth, they form an integral segment for the global population. And Migori County, just like any other county, is one of the county that is youthful, with about 25% being between 10 to 19. And these people, if they are given, they provide an opportunity for the country's development. Next. So previously in Migori, and when I say previously, I mean below 2017, going to 2016, the adolescent and youth services were not provided in a multi-sectoral way. Of course, each sector had something to do, but each did their own way, at their own level. Then we realized the challenges that the adolescents face, like a teenage pregnancy, HIV infections, sexual gender-based violence, among others, were associated to lack of this holistic approach. And then that's why the county envisioned the need to have a multi-sectoral approach and bring everyone on board to tackle these issues. Next. So what the county did, the first thing was to appoint a focal person for the adolescents and youth, who then mapped all the relevant stakeholders for the adolescents and youth. We brought the young people together. We had focused group discussions and came out with 6 priority areas. And we established a task force, a coordination team from all the sectors that has been led by the County Director Teacher Service Commission. Next. So the task force led the development of the multi-sectoral action plan, which is a 5-year plan that is costed. And after it was launched at the end of June 2018, then all sectors were able to align all their interventions in line to that action plan. Next. So the overall goal for this 5-year action plan is to improve the health and well-being for the adolescents and youth. Next. So the 5 priority areas that came out from the young people was adolescent pregnancy, HIV/AIDS, sexual gender-based violence, advocacy, coordination and governance, and monitoring and evaluation. And each had specific objectives. And one that is of great concern was the reduction of teenage pregnancy by 10% by the end of 5 years. Next. So the results will be based by the midterm evaluation. We are just done with the 2.5 years of implementation. Next. So we recently launched the evaluation report that is looking at the implementation period of July 2018 to December 2020. And that photo you're seeing there is the county commissioner that launched the report, handing over to the TSC director, who is the chair of the task force. Next. So among the findings for the adolescent pregnancy, in 2016, which was our baseline, was 37% among the women that came for the first antenatal clinic in our facilities, 37% were the adolescents and youth. After implementation of the action plan, following the interventions that we implemented, by end of December 2020, we had dropped by 16.2%, giving us a 21% drop. Next. So this is absolute figures showing the uptake of the contraceptives among the adolescents and youth, and you can see it has been on continuous upward trend. Next. So in terms of HIV, which was another priority area, we realized that we still have some much more efforts to do. However, we've seen that the positivity rate has increased over time, but these are associated to the strategies that we are using, like targeted testing, that we test the specific groups that we really feel they are at risk. Next. So in terms of strengthening the sectoral M&E monitoring for all the sectors, we have a tool that is a web-based that we track all the activities in line in the line ministry too, though we've realized that as we track, it is the health department that is taking lead. But so it guides us in knowing what are other sectors also doing, as we agreed as a sectoral approach. Next. So out of that, we've been making a regular generation information products that has been helping us even in advocating more of our current status. For example, in terms of the teenage pregnancies, the areas that you're seeing highlighted in red, they are showing the wards that are having high teenage pregnancies. And this we do involving the political wing so that they're able to assist us in tackling these issues as low as at the community level. Next. So as evidence that we are really working together with other sectors, this is data from the Department of Education. And you can see it is showing us the primary and the secondary teenage pregnancies, the ones that dropped out and the ones that are readmitted. If you can see for 2020, we have a high number of adolescents that were readmitted and few dropped out of school. Though we have high cases that were reported to be pregnant, it's because now we have enhanced the reporting of these cases, and the high cases of readmission, we brought even the ones that had dropped years ago. Next. So also as evidence from other departments, this is from the children's department, they also have their data that they analyze the sexual gender-based violence cases, and they're able to analyze by the causes. You can see we have the child marriage, the physical abuse, emotional abuse, sexual exploitation, there's incest. So, and you can see child marriages has been kind of on upward trend, but they intervene as they come across. Next. So this is still, this is gender and probation department. Of interest in here is that from the probation that works closely with the judiciary department, we've realized that through the collaboration, they are able, those adolescents that are accused of crimes, or they're not just left or even jailed just without caring for them. We had at least 117 that were rehabilitated and 7 were attached to local artisans. So despite having these juvenile crimes, the probation and the judiciary, they have their own ways of supporting these young people. Next. So this is still analysis for the sexual and gender-based violence. For the first, you are able to see about 52% of this sexual and gender-based violence were related to defilement. And we had a good number of around 34% that these pregnancies were due to child marriages. But when you look at the end of 2020, the percentage for the child marriages had reduced to 8%. This is because the child department has come so much strongly to even dissolve these child marriages, and these children are getting back to school. Next. So of course, there is much to share from Migori, but because of time, but I can say what we've learned from this evaluation is that key learnings have been generated that will guide the next implementation, that is the remaining 2.5 years. And we realize that emphasis will be more on inclusion of adolescents living with disabilities. In our action plan, we realized that we did not include this special group. Then we realized that the pregnancies are more in the primary schools. So our interventions will be targeting mainly the adolescents in the primary schools. Then we need to strengthen data management and research, and enhance advocacy for increased resource allocations. There is increase in allocation, yes, generally, but it is very minimal. Then also we need to advocate for disbursement and utilization of the adolescent and youth funds, fast track sexual and gender-based violence responses, and adoption of HIV prevention and treatment cascade. Next. So overall, what we can say is that an all-inclusive and well-coordinated multi-sectoral response to adolescents and youth can actually spur an action to address a common goal. And this approach can be used in other counties and countries that have similar problems like our county. And it requires a good political will, passion, and commitment. So despite also the improvements that we've realized in the results achieved across the priority areas, there is need for us to learn from the gaps that we've seen and scale up the best practices. Next. So I wish to appreciate the young people. It's because of them that we are doing all this. The Migori County government and the national government, the task force led by the former TSA director who was now retired and has added over to the director education, and all the implementing partners. And thank you all for listening. We wish to share more, but because of time. Thank you so much, Dr. Jean. Back to you.
Thank you so much, Lily, for sharing that robust experience from Migori County. And that was a real multi-sectoral approach right there. Thank you so much for that presentation. And now we move to our final presentation from Wako Banchale, who is working with AMREF Kenya, and is going to share the experience also from Samburu County, that is the use of Manyata model to influence social and behavior change to improve access to family planning and reproductive health services in Samburu County. Wako, if you can hear me, kindly share your screen. And karibu sana, welcome. And
Thank
just a
you.
reminder to all of us, if you have any questions, kindly put them in the Q&A session. My colleague Eva will be looking at them. Thank you. Karibu Wako.
Thank you, Dr. Jean. Do you see my screen kindly? Hello?
No, not yet, not yet.
Are you able to share from your end, kindly?
Mary Thiongo, kindly assist. Mary Thiongo.
Yes, Dr. Jean.
Let me see if I can find his presentation.
Please share Wako's presentation. He's unable to project.
In a moment.
Yeah, we're working on it. Wako, right? This is correct. Is that correct? Can you guys hear me?
Yes, thank you. Thank you very much.
Okay.
Thank you very much.
Sure.
Yeah, good evening all. I hope I'm audible. Hello.
We can hear you.
Okay, I'm presenting for Manyata model innovation under DESIP project. DESIP basically is about delivering sustainable and equitable increases in family planning in Kenya, targeting about 19 counties in Kenya, which is performing below 50% in modern contraceptive prevalence rate, where Samburu County is included. And we are implementing this through support of UK Aid in a consortium led by PS Kenya, summing to about 7 consortium. Next. Yeah, background of Samburu, North Sub-County, where the intervention is currently going on. As you can see, it covers about 7,000 kilometers squared, with a population of 67% and over 80% being pastoralist. And I want to share some few RMNH indicators which are not performing good, like contraceptive prevalence rate is at 22%, with high teenage pregnancy at 25.7% and maternal mortality at 472 per 100,000 live births. If you look at these indicators, they can be able to be, reversed if, let's say, modern contraceptive methods are embraced by the community. So due to many factors which has contributed to this, then the county is performing poorly in terms of RMNH indicators as shown by the statistics from Kenya Demographic Health Indicator Survey for 2014. And as you can see in this vast sub-county, we have like 26 health facilities with only 10 community units. As you are all aware, the direction that we are taking now, the community should be owning their own health through community strategy. And in such a vast area with only 10 CU, you can imagine the service delivery and of course the access to health. Next. Next, please. Now, Manyata model, what is it? Sorry, go back, please. Yeah, this is an approach of working with the lowest administrative structure, that is the homestead, to link Samburu communities to the formal health system for increased utilization of family planning services. So what are we doing? We are doing in terms of now creating demand for the services, going to the lowest level where the community lives. We said these are pastoral communities who are just moving with their livestock from place to place in search of pasture. So we need to go down to them so that they can be able to utilize the family planning services. Next, please. Now, the goal here is to contribute to increased uptake of FP services. As I've already said, DSIP is biased towards family planning, having in mind these are hard to reach communities, so that we bring on board all practical social partners, including elders who are gatekeepers of the community, up to the target individual, adolescent or young person who is living within the society at homestead level. Next. Now, we are working on a learning question, which we are piloting in about 6 health facilities. And we want to answer the question, how can DSIP most effectively modify community health volunteers demand creation initiative of the Manyata model in Samburu North Sub-County, in Samburu County to promote uptake of family planning services. So we wanted to go down to the community so that we create demand for the services, because we felt from our initial inception and findings through the assessment at the facility, we found out that demand creation or the demand for the services is where the problem is, because communities are living far away from the health facilities. As you have seen, it is a vast sub-county and communities are pastoral. Even getting information is an issue. So we felt demand creation is the way to go, and that is actually why we came up with the Manyata model, which is actually relevant to them and a cultural sensitive way or approach of now reaching the lowest administrative unit, which is the homestead. Next. Next, please. Now, this is how the model looks in terms of the design. As you can see, the inner white circle is where our target groups are. That includes women of reproductive age. These are the main target group. But our intervention focuses again at the adolescent and young or youths, people with disabilities, and poor rural women who are far away from health facilities. So the inner circle is where we want to reach. And for us to reach this inner circle, then we have to go through processes that includes now involving the elders, involving other family members, including the head of household, that is the male. And through such interventions as household visit by CHVs, interpersonal communication, community-based distribution activities, and of course, integrated outreach services because of the access issue. Of course, for us to do again this, we must put in place all the systems strengthening approach, including now equipping the health facility with the FP commodities, use of now, health facility in charges so that referrals by CHVs can be able to be handled well by the healthcare worker equipped with commodities, knowledge, and such like things. Then through structured dialogue with cultural elders and adolescents and on sexual reproductive health rights. So who are the task force or workforce behind this community health volunteers? Who are the CHVs, youth champions, and male champions. So after now we package information or communication for these specific target groups, then we do dissemination of this group messages through CHVs, youths, or male. And as you can see, the linkages that support the system is like sub-county health management team, private sector, and Nyumba Kumi initiative. So these are the foundation on which this model is based. Next. Now, in terms of results that we've so far achieved, in the 6 facilities that I mentioned, out of 6 facilities, actually 3 facilities are low volume in terms of service delivery uptake, that is family planning, and 3 of them are high volume health facilities, and these facilities were selected using non-biased scientific criterion including, let's say, capacity of healthcare workers, consistent reporting, availability of commodities, and such like things. Then we came up with now studying how maybe the trends for FP uptake has been, doing over time. As you can see, July 2019 to June 2020, which is in green, and July 2020 to June 2021, there is some increase in uptake of, family planning, especially the long-acting reversible contraceptive methods. Why are we interested with that? It is because, these methods, when a mother embraces this method, it cannot be done by a mother alone. It has to be shared with the couple or the partner. Unlike when they use Depo-Provera, the most common methods that they use, it is because maybe they don't want their spouse or the partner to see when they are on another method or a method of family planning. As you know, culturally, children are like pride of our society, so you can be able to have as many children as possible. So over time, we've realized there is some increase. This is absolute number, not percentage. So as you can see, the trend is not bad, save for a few facilities like Nachola, which showed some drop. Next. Contribution to policy or program advocacy, adolescent and youth social networking. Now we develop WhatsApp group where there is issue of network availability because most of the areas don't have networks. Then the tag team approach, the CHVs, are grouped into small groups so that they give the relevant information. We had CYPs being increased, addressing unmet needs among adolescents and youths. Then homogeneous groupings of the target beneficiaries. So we group them in terms of adolescent girls, in terms of young mothers who are married, in terms of women of reproductive age, men. So we give them their package of messages. Next. So lessons that we learned: male involvement is very key. Women empowerment and adolescent and youth empowerment. Unmet needs are actually very high. And then social inclusion, of course, is also very important. We found out that women have more information than men, and health system strengthening actually is the way to go for us to ensure service delivery in our community. Next. Finishing, this is how we do community dialogue session. Next. For us, for some of us who have never visited Samburu, this is a typical Samburu Manyata and what we are talking about. Thank you very much.
Thank you, Wako, for that presentation. This was a very informative session. We have been taken through the legal and policy environment. We have seen the trends and perspectives with regards to SRHR. We have also learned some lessons from Migori County and also some lessons from Samburu County on innovations to reach out the vulnerable. So I think we have a lot we can do as a country. And now I take this opportunity to invite my co-chair, Eva, to take us through the Q&A session. Welcome, Eva.
Thank you so much, Jean. So there are no any direct questions directed to the panelists themselves, but in the essence of time, I think if any questions come up, the panelists can address them through chat. So thank you all for the very innovative and very interesting perspectives you have shared. I think the main takeaways from these sessions have been that we have the policy framework we have all the legal frameworks, and because of
hapo nakuja sahi.
Sawa.
Niaje babe?
Poa sana.
Mambo.
Poa.
Aki nimekumiss.
Semia.
Alafu cheki. Guess what? Ile surprise nimekuletea.
Walai.
Niko nayo, situpatane Makuti. Ile bezi huko hivyo nyuma maja kunanga watu wengi.
Sawa.
Ni sawa. Nyemba mbalanga zinakujanga hivyo. Hapa tenga. Unasemaje? Na nimekusalimia. Niaje? Poa sana. Alafu nini unafanya hapa? Unajua hapa mbalanga zimetoka mbinguni zikanizukia. Hata mimi zangu zinanikujia hapa sasa. Inaongojea, kuna mtu naongojea. Hata mimi kuna mtu naongojea. Allah. Aliniambia saa 12 nikuwe hapa. Mimi naongojea mwende wangu. Mimi naongojea mwezi. Wallahi kwa nini na nani huyo? Mimi mwezi. Wangu kwanza nywele yake imeenda hivi. Inakaa 1. Na mabua. Sasa wangu amenoa hivi, alafu zikaenda hivi mbili. Wako wamenyoa? Wangu nywele zingine mbili hivi. Sasa wangu ukimwangalia ni black beauty. Wangu ni black beauty. Mbona ni matwin? Mwende ndio huyu. Mambo. Haki mwende wako kongoja. Mwende wangu. Acha naongea na mwende wewe usi mwende wako. Ule mtu wangu.
Si tupeane.
Tuletea ndio hii. Tuletea simu.
Umeleta.
Nilikwambia mwende hawezi fanya kitu.
Lakini wacha nipeje ananipea.
Yako ni hii. Lakini sasa wacha nikutumie imbaki.
Thank you very much. Very
Okay.
interesting, and it is getting better and better. And we are now moving to our last session for the day, and we have Michelle Decker and Virginia Duta taking us through the session. Welcome, Virginia and Michelle.
All right, so we are headed to our last session where we are looking at gender and gendered impacts of COVID-19. So my name is Virginia Nduta, Executive Director, Women's Empowerment Link, and I'll be introducing the panelists as they come. So our first panelist will be Dr. Beth Kangwana from Population Council, and she'll be looking at the topic of gendered economic, social, and health effects of the COVID-19 pandemic and mitigation policies in Kenya, and specifically focusing on the evidence from a prospective cohort survey in Nairobi informal settlements. Welcome, Dr. Beth.
Thank you very much. Can I share my screen?
Sure.
Okay. Okay, I hope you can all hear me and that you can see my slides. Just confirming that you can see my slides correctly.
Yes, we can, and we can hear you. Thank you.
Okay. So hello everyone. I'll be presenting on the gendered health effects of the COVID-19 pandemic, and I'll be looking at evidence from a prospective cohort survey that was carried out in Kenya. I'm presenting on behalf of the Population Council Kenya's COVID team, which is led by Dr. Karen Austrian, and also passed through the Presidential Policy and Strategy Unit. So the objectives for today, I'd like to discuss as follows, is to understand the health effects of COVID-19 on Kenyan adolescents. I'll also include gender disaggregated data from both boys and girls to be able to effectively identify the gendered impacts. And then I'll also present data that's been generated that will then be able to guide post-COVID-19 adolescent programming and policy in Kenya. So the presentation will be focused on teen pregnancy and early marriage and gender-based violence and safety. In terms of teen pregnancy and early marriage, the study collected information on teen pregnancy and early marriage and also the drivers of these among adolescents. And with gender-based violence and safety, the study assessed the tension and violence experienced by adolescents. I shall also explore general issues regarding general access to healthcare services and present basic descriptive statistics where I'll compare different sites and different age groups. So here's an overview of the data collection. We collected data from 4 different counties, namely Nairobi, Wajir, Kilifi, and Kisumu. And across each of these counties, we collected data from selected areas or regions within them. When it came to the sample size for Nairobi, Wajir, Kilifi, we were able to collect data, quantitative data on slightly over 1,000 adolescent boys and girls. In Kisumu, we collected around data on 600 adolescents. We had data collection across 2 time periods. The first time period was June to July 2020, and then the second February 2021. And the data was collected from adolescents who had originally formed cohorts from studies that we had previously carried out. This includes the Adolescent Girls Initiative Kenya study, AJIC, Nisitu study, NIA Dream study, which was carried out, NIA study, which was carried out in Kilifi, and the Dream study, which was carried out in Kisumu. We aim for a ratio of 2/3 women, females to male. We had slightly more females so that we could be able to have enough sample to detect sexual and reproductive health issues. So during the data collection, school closures were imposed by the COVID-19 pandemic between March 2020 and September 2020 for grades 4, 8, Form 4, all the way up to December 2020 for all other classes. So the data that we collected over June to July 2020 took place during the school closures, and the data which was collected in February 2021 took place after the schools had reopened. So this slide shows data on adolescents' access to healthcare services in the past month. In order to collect this data, we asked adolescents, was there a time in the past month that you were sick, needed a health service, medicine or product that you did not get? We see from this slide that adolescents were more likely to skip healthcare in 2021 compared to 2020. So, and we also see that in both years, girls were more likely to skip healthcare services when needed compared to boys. So the girls are being represented in the green bar and the boys in the blue bar. The main reason that was identified for skipping healthcare services was cost. And this was followed either by lack of services or medicines or fear of being infected by COVID-19 if they presented at the health facility. In this slide, we present data on adolescents reporting encountering increased emotional, physical, or sexual violence acts. Here the green bar presents data collected in 2020 during the school closures, and the blue bar in 2021 when schools were reopened. Over time, from 2020 to 2021, generally we see no real difference across data collection rounds in experience of emotional and sexual violence. However, we see an increase in physical violence from 2020 to 2021. And for all reports of violence across the 2 years, half to 3/4 said that it was happening more than pre-COVID-19. This is not shown, but when it came to gender, we saw that there was no gender gap for experiencing emotional violence. We also saw that physical violence was experienced more by boys compared to girls, and that sexual violence was only reported by girls. This slide presents data collected in 2021 only on pregnancy and marriage. The data collected in February 2021 highlighted that pregnancy among girls aged 10 to 19 years remains a problem. Among 15 to 19 years old, overall, we see that around 4% of pregnant or recent girls were pregnant or recently had a baby. And this represents over 100,000 adolescent pregnancies. The highest percentage of girls who were pregnant or recently had a baby was in Kisumu, 13%. This was followed by Kilifi and Nairobi. Almost all girls who got pregnant during the school closure period said that their pregnancies were either not planned and expressed apprehension about the future of their education. What we also saw from the data was a noticeable proportion of adolescent girls were married during the pandemic. Almost 3 out of 10, so around 29 girls reported that they had got married after the COVID pandemic occurred. And although this is not shown on the graph, among these girls, around 2 in 5, so 42% confirmed that they got married after getting pregnant. And incidentally, in Wajir County, a majority of the married girls, so around 87%, stated that marriage was their choice. This was echoed by close to 74% of girls in the overall study. In addition to personal decisions taken by adolescent girls to get married, other interviewees pointed towards the pandemic and also financial reasons. So in terms of pregnancy and marriage, we also collected some qualitative data. And what was coming through from the qualitative data was that the numbers we saw in pregnancies and marriages can be attributed to school closures and lack of money. And I'll just go through some of the quotes. One quote, which was a female stakeholder in Kilifi, said, "It gets to a point where a parent is unable to provide her child with sanitary towels, so that promotes early pregnancies because a motorbike rider offers her 2,000 shillings and it gets to a point where they engage in sex and she gets pregnant." And then there was a quote here by a 17-year-old adolescent girl who's currently out of school, who said, "My cousin got married in August 2020 this year. She said that she was wasting her time not going to school and she's not married, so she's decided to get married." And finally, a 17-year-old adolescent girl from Nairobi was quoted as saying, "During Corona, someone feels that instead of staying at their home and reading, she'd rather go to the guy's place and stay with him." So those are just a few quotes. And just some recommendations and next steps. So I've only presented data on the health effects, and my colleague Karen Austrian will be presenting data on the economic and social effects of COVID-19 tomorrow. So generally across all the different sectors, these are the recommendations and next steps we came up with. The first is to raise adolescents' voices by supporting their participation in all public decision-making through the COVID response, recovery, and beyond. And the thinking is this could be done by ensuring valid representation of adolescents in the development plans through relevant task forces at all levels. The second recommendation is act to address immediate and ongoing risks of gender-based violence exacerbated by COVID-19. And again, here the thinking is that the government could act on this by recognizing GBV, child protection, and sexual and reproductive health services as essential services, including safe houses, which must be maintained during the pandemic. There was another recommendation to establish a national multi-agency adolescent task force whose mandate is to develop a framework for an integrated multi-sectoral adolescent resilience and development strategy. And the thinking behind this is the task force would ideally develop a multi-sectoral national adolescent action plan with accountability mechanisms. And the team would also review current adolescent policies to ensure that they're cohesive. And then 3 more recommendations. One was to establish county adolescent multi-sectoral working groups whose mandate is to develop context-specific integrated county adolescent action plans, oversee implementation, monitor progress, and report. And the establishment of these working groups could be fast-tracked by building on existing platforms such as the county teen pregnancy working groups. Then there was a recommendation to use data and evidence at county and national levels to guide development and prioritization of activities for adolescents. And this data could be centered around prevalence of risk factors for adolescents by age and gender. And examples of data include transition rates to secondary school, rates of child marriage, and prevalence to SGBV. And finally, a final recommendation is to invest in adolescents with new and not repackaged investments to prevent the worst outcomes of COVID-19 for adolescents. And this could involve leveraging on technology-supported learning to improve equity in education and close the digital divide. There's also additional financial assistance might also be crucial to support development of national policies. Thank you. That's the end of my brief presentation.
Excellent. On to our next presentation. Host for this session, Dr. Michelle is a professor and she will be presenting among yes, welcome, Dr. Michelle.
Thank you. Thank you so much. I'm thrilled to have a chance to be part of this panel and begin to share some of our work. I'm gonna, if I may, I'm gonna share our slides. And I'm really thrilled to give you a little bit more let me make sure we're running this slide properly. Sorry, toggling over and getting it started, just making sure we're all set here. Hopefully you can all see this. And I'm thrilled to present really on behalf of our team. You learned a little bit about this study earlier in the day from Dr. Gatanji, and what I'm going to do is transition us into some of the other learning on gender dynamics, GBV, and safety during the COVID pandemic, specifically with our cohort in Nairobi. So this is lovely to have a chance to follow the Population Council work in this area. And then I'll transition it over to Professor Grace to get into the social and economic elements of this. I'm assuming that you can see me, and I'm going to keep going forward. And I think just a little background on this, we're all really well aware that those underlying disparities in norms in mobility, economics, and safety can all be amplified in a crisis like the COVID-19 pandemic. And we've had a chance to hear throughout the morning specifically about GBV. It's endemic globally before the pandemic, right? And we've heard about the ways in which the pandemic can amplify risk through more time at home, stressful circumstances, gaps in support systems, et cetera. And we're so concerned about this, of course, because of the impact on SRH and other key developmental, physical, mental health outcomes for young people. So you heard a little bit about our Nairobi respondent-driven sampling survey. This fielded initially in 2019, and we had an opportunity to follow this cohort at several points in time over the COVID pandemic. And what I'll highlight for you is just some of the domains. We're not going to be able to cover all of the results today, but you heard earlier about the SRH elements. We also collected data on menstrual hygiene, economics, school dynamics, family relations, social, mobility dimensions, norms, and violence and safety. So just to give you a sense of what's available through this. And these data will become publicly available very soon. We have some qualitative elements along with this. And of course, those ethical protections for remote survey data collection and the ethical elements as well for gender-based violence and other sensitive topics. So what did we hear? What did we learn from this cohort in Nairobi that included both young men and young women? Our results from our 2020 wave actually really showed that the sexual violence that we were picking up on as a result of the survey was prevalent and was really coming primarily from partners, dating partners, sexual partners. You see in the green, there is some extent of non-partner sexual violence, but for our young population, for unmarried youth, the primary perpetrators of sexual violence were actually their partners, people that they were in a dating or a sexual relationship with. So it's really important for us to think about because of the concern about non-partner sexual violence, violence being perpetrated potentially by household members, which is absolutely part of the picture as we heard beautifully earlier in the day in Mangori and other settings. But just to remind us as well that people that youth are in, existing relationships with are also experiencing sexual violence and partner violence from those partners. So expanding our lens a little bit for our youth population to acknowledge the experiences of gender-based violence. When we looked mid-pandemic again, this is the 2020 data, we found about a 17.1% prevalence of past year physical or sexual violence from partners. And very similarly to the results that we heard from a wider range in Kenya, just now from PAP Council, we saw as well that there was some of that violence was before COVID only. Some of it was during both time periods, and some of it actually had really initiated during the COVID pandemic. It's a really interesting population when we're thinking about this because, of course, not all of our young people are cohabitating. They're not necessarily married, and yet they're still experiencing physical or sexual violence from their dating partners or their sexual partners. We wanted to understand some of the risks for past year IPV. You can see one of our quotes from our participants are really speaking to alcohol, stress in the household, financial issues and lack of money, and the conflicts that can occur around scarce resources and really amplified during a pandemic situation. When we looked at some of the risk factors or disproportionate areas for IPV, we saw that there were differences by housing structure as sort of as a proxy for SES. Certainly people that were not living with their parents nor their partners were at greater risk for partner violence. And very interestingly, those that were home less since the COVID restrictions also experienced an elevated risk for partner violence. And then at the very bottom, you're seeing that women that are really have gaps in ability to meet basic needs. Again, very high risk. That was our highest risk group for past year partner violence. One of the questions that we've had and that I think is plaguing policymakers and programming right now, and we'll hear a lot about it tomorrow at the panel specifically on GBV, is sort of how is this changing through the course of the pandemic and what can we do around risk? This is a visual looking at trajectories of partner violence, partner-related fear and safety from before the pandemic, mid-pandemic, and late pandemic. And the green is the safety. Yellow is fear, partner-related fear, and the red is the partner violence experiences. So the quick takeaway on this that you should be seeing is that it's really mixed, right? Some people are moving from experiences of violence into safety. So that's a win for us in public health, right? And then others are moving out of safety into risk, either fear of partner violence or experiences of partner violence. And so this is a little bit more jumbled than we might have anticipated when we think about sort of the impact of the pandemic. We're starting now to look at sort of what drives these different elements in this trajectory. We saw that 66% of our sample, this is women only, had experienced that sustained safety. For some women, they actually had a cessation of violence that occurred during the pandemic. That was about 6.9%. But what we see more often is the intermittent IPV, sometimes happening during the pandemic during different points, or initiated partner violence during the pandemic. In the interest of time, I'm not going to go into all of these details on this, but I think that, you know, when we think about what we need to do programmatically in terms of COVID recovery, as well as programming, understanding these patterns and how they change over time is really helpful for us when we think about positioning our programming to be most effective for those at greatest risk. I do want to touch as well on help seeking. And again, this is our Nairobi youth cohort. So not broader to the entirety of Kenya, but just to really showcase two things on this slide. One is that help seeking levels are quite low for both partner violence and sexual violence at both time points in the pandemic that we surveyed. But what you're seeing here, comparing the green to the purple, is that actually we saw an increase in help seeking for both partner violence and sexual violence between the two time points. And this is really heartening. A lot of our COVID response, particularly for youth, has been about getting the word out about support services, making sure people have connection to care. We wish that these numbers were at 100%, where people know where to get help and are getting that help. But I think this is really heartening when we think about the work of the COVID response task forces in getting the word out about partner violence and sexual violence, where you can actually get help. And you can see as well in this quote, the impact, and we've talked about this throughout the day, the impact of those curfew hours. So it's meant, of course, to mitigate transmission and contain people for infectious disease control. And then the flip side of that is that sometimes these curfew hours are winding up trapping people into dangerous situations with partners or other individuals that they may really actually be at risk from. All right. So lots more to unpack there, but I actually, in the interest of time, am going to transition us over to Professor Grace, who is going to give us a deeper dive into the gender dimensions of social and economic impacts, again, working from our cohort in Nairobi. So thanks.
Okay, thank you so much, Michelle, for that. And I will be concluding because I can see we have actually fairly little time, so I won't say much. And I think I want to pick from where Michelle stops. You have seen the variations, gender variations within the impact of COVID and all this. And I also want to mention that this data was taken progressively. So whatever is being seen here, there is a variation from when it started and it progressed to the rate parts of mid-pandemic and early pandemic. Let's go to the next slide. So the variation, the socioeconomic variations, let's move to the next slide. Yeah, some of the questions that we are interrogating here, and I don't think I want to belabor so much on the statistics because you can see them and have the slides later. Needs within the participants in the study between men and women, the young men and women, and even without labeling on the data, to start with, the minute the pandemic came immediately, of course, there was a socioeconomic shock, and more specifically, an economic shock. And when you look at the variations, there is still the way the men were able to cope with it and the way the women were able to cope with it, there is still variations. Although both were affected by the pandemic, as we progressed towards the end of the year and as the pandemic was moving on, again, the impact became stronger. And this, we all understand, the businesses went on declining and the pandemic became stronger to everybody. It affected almost everybody. And again, because of the social dynamics, looking at what, next slide, looking at what men and women do. And most of these were in the low income bracket. If you look at the resilience that was seen, how the progression moved, ability to meet basic needs, for example, between men and women, although there were some improvements over time, simply because of the peaking in business, sometimes new dimensions of business coming in, gender differences were still sustained, but more so data showed that women became more affected. Let's go to the next one. And by so doing, there is one variable that I may want to pick here, that is the return to school load. We also looked into this. And again, a higher proportion of young women did not return to school. And this has been spoken about by almost all the speakers who spoke. And this is, especially in the round 3, the final stages of the pandemic, or, as compared to young men. Of course, one of the reasons that these women and, there was a variation between men and women, one of them was access to school fees, which is gendered, by the way, access to, also teenage pregnancies, which is also gendered. And I think when you look at the overlying cultural dynamics, whereby even without pandemic, when it comes to a family to choose between a girl and a boy to take to school, most likely the boy will take the preference. So the pandemic, because of the dwindling economic, resources, the pandemic increased the dimension of the gender within this. And then we looked at what were some of the reasons, for example, that made girls, not return to school as much as boys, and what happened. Look at clause 2. I got married and could not go back to school. When you look at that, you see who are saying that, which gender is more affected. And in another case, I got married. This was mostly affected women. The next, and these are also sex specific. For example, when somebody says, I got pregnant, may I here state this? When getting pregnant takes two, by the way, a male and a female. For example, if both are students, unfortunately, it is the woman who does not go back to school because of that pregnancy. The boy will continue with schooling and all this. Or my parents moved from where we were living during coronavirus. Again, it became more specific to women and all that. I decided to drop out of school. If you look at that, there were fewer women who made a decision as compared to the boys. And the school remained closed and all that. And one dimension that I may also mention here is when it comes to labor, and especially assisting parents during the pandemic, women, of course, were more, because most jobs were in the socioeconomic lower bracket. So what conclusions can we make, or what are we taking away? Because I want to make an end to this. One, the intimate partner violence and other violences against women remain prevalent. What do we mean? Sustained risk through the pandemic period. That, like Michelle has said, there was a sustained risk to women, and she has alluded as to why more young women than young men were affected. And again, the intensity was also heightened during the pandemic for some, but not for all. For some women and for some men, it was heightened, but the vulnerability of women literally increased. The economic challenges persisted for the youth, especially young women, and again, because of all the overriding factors, and therefore, gender, and I have alluded to some of the reasons. There are quite a number of others. We were just picking on the key highlights. And school fees was more likely to be a barrier for young women. And again, let me say this, it becomes a barrier for women because not just them, but some of them have also dependents whom they have to take care of. And finally, sustained needs for, for a focus on economic expansion for the youth. And I think this has been alluded to by the earlier speakers, that we need to think during a pandemic like COVID, how do we really sustain the youth, the economic vulnerabilities? Because as we have seen, the pandemic affected some of the activities, economic activities that affect the youth more actually even than adults. And therefore, how do we transform agenda transformation in depth? spoke about this. It's not just telling the government, this is like, it is getting into action and finding out what we need to cushion the youth, especially young women, against such pandemics. And finally, a need for gender disaggregated monitoring for recovery indicators. We need to know where we are. The government had some incentives, but did they reach the youth? Like I remember personally, there was a tax waiver for some period of time, but did this reach the youth? Most of the youth are not even in formal employment, and the tax waiver was literally for people who are in formal employment. Therefore, in conclusion, I say this. The social stigma, for example, or the social impact of COVID-19 on our youth, definitely the women, young women getting pregnant, especially when they are school, not only does it affect their economic status, but there is also a heightened social stigma, which of course does not affect the young men, because like I've said, and as I conclude, when we see girls, like the earlier speaker was showing girls pregnant, who has made these girls pregnant? There is no time sometimes to know that this teenage school girl, or this girl who is pregnant, or this woman who is pregnant, all we know is that there was heightened cases of pregnancies. And unfortunately, some of these cases are of the household. And with those few remarks, I want to thank all of you and appreciate you. This we shall continue even tomorrow. And the final thing I want to say is that COVID-19 has a gender dimension. Thank you so much.
Thank you. Thank you so much. I would want to invite Dr. Michelle to note any questions that we had during that particular panel discussion. Thank you.
Wonderful. Thank you. I know we're getting late in the afternoon and evening. I'm scanning here for questions. And I know we are going to be continuing this conversation with a fantastic panel that's actually kicking off our day tomorrow, that is bringing in some of the programming, and we're going to hear from a wider audience, particularly on the GBV pieces. I will invite people, if they have a question and haven't had a chance, go ahead and put it in the Q&A. I'm not seeing anything specific to this panel, but I think Beth, Dr. Grace, myself are here to respond to questions as they come up. And let's see. I think maybe with that, we will close the session so that we can move it back, I believe, to Mary. I'll be passing the baton to Mary. Thank you so much for this great session.
Thank you so much.
Thank you, Michelle. Thank you, Virginia, for sharing this last session. I hope all of us are still strong for the day, and for the others who are beginning their day. Just to thank all of you most sincerely for the presentation you have had since 2 p.m. The panelists, great discussions have taken place. We truly appreciate these discussions. For the chairs and co-chairs, again, to thank all of you. Just to note that tomorrow we shall be starting a little bit earlier. We missed the session of edutainment, and this will be captured tomorrow. So I hope Michelle and team, you can help the JHU team to set up us a little bit earlier so that we can have edutainment as we begin the day. For all of you, thank you for the presenters, thank you for the audience, and thank you for being there. I would conclude by saying we are doing all this for the betterment of our young people, adolescent and youth, and we know that the investment is worth the effort, and we'll be able to inform the right policies, programs, and advocacy. And with that, I would like to say the meeting is closed, and we'll see you tomorrow at 2 p.m. Kenyan time, 7 a.m. Eastern time. Thank you, all of you. Goodbye.
Thank you. Bye.
Goodbye. Thank you. Thank you, and goodbye.
Thanks.
Bye.
Bye-bye. Goodbye. See you tomorrow.
Bye. Thanks, everyone. Look forward to seeing you tomorrow.
Bye.
Bye.
Genius level 1.